Hi, everyone. We are recording today. Well, good morning. Welcome. Thank you all for being here, for joining us. We're so excited. It's so short up here. We're excited to have you. We're excited about the speakers and the program that we have lined up for you today. My name is Tracy Farrell. I'm communications lead at SomTech. We are a design and technology consulting group in the School of Medicine Dean's Office. And I want to just run through a few notes before we begin. Restrooms are through these doors, out the second set of doors in the hallway. We are live streaming and recording the webinar via Zoom for virtual attendees. And in that vein, there will be some photography throughout the day as well. So when you have a moment, if you haven't already, if you could complete your media consent form in the packet and return it to one of the volunteers, we'd appreciate it. Just the two highlighted fields. And now for our opening remarks, please join me in welcoming to the stage UCSF School of Medicine Dean Talmadge King.
So good morning and welcome to a happy Friday, I guess. They all seem to run together to me anyway. The weekends are 2 days too short as usual, but happy Friday. This is an important meeting. We feel that focus on health equity in data interpretation, participatory design, and research are important endeavors for our school to work on. We must be prepared as an institution to ensure health equity throughout every facet of our work, from the data we collect and analyze to the tools and interventions we design and the partnerships we cultivate. We feel that equity should be a founding principle in those relationships and in that work. We cannot claim success unless every individual, regardless of their background or circumstances, has access to the same opportunities for health and well-being. That is why events like this, Health Equity Community Building Symposium, are so crucial. It's not merely a gathering of minds, it's a rallying cry for action. It is an important opportunity to build a shared understanding and community around our commitment to health equity. It's also a chance to forge and strengthen connections that will drive meaningful change in our commitments. But as we embark on this journey, we must also confront our past. As an institution, we cannot ignore the injustices of the past, nor can we allow them to persist into the future. It is only by acknowledging and addressing these systemic issues that we can truly pave the way for a more equitable future. This is hard work we have to do and continue to do. But we have done and will continue to do hard things. So let us come together today, not only in celebration of our achievements, but also in recognition of the work that lies ahead. Let us recommit ourselves to the pursuit of health equity in all that we do. And let us build a future where every individual can live a healthy and fulfilling life. Today, we look forward to a lively discussion and insights from our panelists and keynote speakers. Hopefully you will be inspired to continued action, knowing that our community is behind you in this challenging time. In closing, I want to recognize one of our, I'm blocking on his name right now, one of our founding members of the Black Caucus. He died at age 97 recently, and he was one of the people who started UCSF on this journey to equity in many ways, and was widely known as a world famous photographer, and had worked with Ansel Adams in the past. And why am I blocking his name? David Johnson. David, so last 2 years ago, 22, David received the UCSF medal. And it was a thrilling opportunity for me I had met him multiple times before, but to sit with him and hear his story. And I just want today to honor him for what he was part of a founding group of people who set in place a complete change at UCSF in the 60s and 70s. So I just want to honor him. But thank you all for being here. I hope you have a wonderful day. And I hope that out of this comes a way for us at UCSF to keep moving the needle forward. We have a lot of work to do, and the headwinds are pretty strong. But our job is to do what we can do from where we are in our sphere of influence and control. And I'm here to support you in doing that. So thank you for doing this. And we look forward to learning from you and coming up with good ideas on how we can continue to work. So thank you very much.
Good morning. My name is Tung Nguyen. I'm the Associate Vice Chancellor for Research, Inclusion, Diversity, Equity, and Anti-Racism, or IDEA for short. I came up with that acronym because whenever people say, what's the big idea? I want them to say equity, right? That's the big idea. We're an institution of generating innovative ideas. I'm here to actually, my pleasure to introduce the moderator of the next panel. It's going to be Nova Wilson, who is a program manager in the Center for Pandemic Preparedness and Response at UCSF, where she has led community engagement efforts for several studies and training programs on bias and cultural humility. Ms. Wilson is a seasoned professional with over a decade of experience in community engaged programming, with a primary focus on adolescent health, pregnant people, and school-based health centers. She has implemented and supported impactful programs that respond to community identified needs. At UCSF, Ms. Wilson contributes to initiatives, to studies investigating the impact of DIB-based virtual reality training on provider empathy toward BIPOC patients, cultural humility training, and public health workforce development. And her passion lies in conducting work that interrupts bias to improve health access and outcomes for Black girls, women, and other historically marginalized communities. Please welcome Nova Wilson.
Hello, everyone. I am wondering where our mics are. We have mics today. We're just going to use our big, strong voices. There are mics? Yeah. They're on the podium. Oh, they're behind your
Behind the screen, I think.
Okay. Hello. It's okay. That's okay. So I'm just gonna talk very briefly, and then I'm gonna have all my people join up. I just want to start by thanking Dan King. Again, my name is Nova Wilson. I work for the Center for Pandemic Preparedness and Response, and I will be talking with our panelists today about their perspectives on artificial intelligence in healthcare and in public health. And now our goal for the time that we have together, it's about 45 minutes, is going to be to explore the panelists' multifaceted implications for artificial intelligence in healthcare, particularly focusing on health equity, disparities, and promoting health equity. And we're all here today because we understand that community partnership is integral to honest efforts to mitigate health disparities and achieve equity, and what we describe as a fair and equal opportunity for health. And as we also know that AI is increasingly touted as a tool to support this goal, potentially interrupting provider and institutional bias to ensure that we really address these disparate outcomes and improve health for all communities, regardless of their background. And so with that, I really am excited about bringing our panelists up to have this conversation. So please come on up here and we can talk together. He took it away. Okay, so we're gonna be playing Pass the Mic.
He's got it. 3 of them.
Okay.
Loud, that's all right.
Okay, all right. Okay. With me here. So I am going to start by introducing our panelists. We are going to start with Solange Madriz, is an academic coordinator at the Institute for Global Health Sciences. Welcome, Solange. She designed, implemented, and monitored global health programs throughout the Americas and the United States, as well as India, and her research focus is on health education professions. Welcome. We also have Jason Davidson joining us today. He's a PhD candidate in pharmaceutical sciences and pharmacogenomics at the University of San Francisco, California. And his research primarily centers around the treatment and utilization of health outcomes for type 2 diabetes. We also have Dr. Mudamita Sushil joining us. Dr. Sushil is a senior postdoctoral researcher at the Baker Computational Health Sciences Institute. She specializes in development and application of AI methodology in healthcare. And Dr. Sushil is experienced in developing large language models for medicine and using them to obtain insights from clinical notes. And finally, sitting next to me, we have Luis Gutierrez Mont, who is a project director with the Division of Prevention Sciences. His expertise includes transgender and HIV treatment, sexual orientation and gender or SOGI data collection, and research with sexual and gender minorities. Welcome to all of you. So my first question today is going to be directed at you, Solange, if that's all right. Given your background in designing health programs globally, what are your experiences or hopes for how AI can support health equity?
Thank you, and good morning, everyone. I have to say that I wear different hats, and I'd like to share with you my excitement about AI. And just to get started, I wanted to get a sense of how many in the room, raise your hand, if you've used ChatGPT. Many, if not all. Isn't it that cool? It's super cool. But when we think about the health equity and the impact that it can have, I would say that I'm very excited. From the global health hat that I'm wearing, it's very, very exciting to have this tool to do different things. The first thing that comes to mind is that, can you imagine if you can pose a question and to whether the person could deserve or not deserve, but to get a treatment or not? That is one of the uses, the clinical application that it could have. And I think that AI could have a tremendous impact, especially in low resource settings where resources are limited. And I feel that the artificial intelligence can have an impact. At the same time, in areas where there are less skilled providers, having AI used for clinical decision making can have an impact, because then more people could have access to healthcare. That is like thinking from the global health perspective. So I hope that, my hope is that, I know that right now we are at the beginning of the use in healthcare, AI in healthcare, but I really wish that they're not thinking about making business, and they're also thinking about the applications that AI can have to bring equity. And so, of course, in low income settings, it will be very hard for them to pay the prices for artificial intelligence that we could pay in high resource settings. So I really hope that through these conversations that there's somebody out there in the industry that are thinking about how can we bring these tools also in an affordable way. That is thinking again from the global health perspective. Then the second hat that I wear is my student hat. I'm a doctoral student at UC Berkeley, and even though currently most of the syllabus, they say like, do not use ChatGPT, do not use this. And I think that that's actually a mistake, because ChatGPT is out there and it's not going to go anywhere. So it's like, I would like to encourage now the professors and to how can we make sure that students are using ChatGPT or any other artificial intelligence product to advance knowledge. So we have to use it now in our advantage, not to restrict something, because it's there and people are going to use it. As a matter of fact, I'm so obsessed with now there are certain generative AI products that you can make images. That is amazing, because for people like me, that art and making things pretty are not my strength. It's now in a matter of seconds, I can make beautiful images. Then I learned a few days ago that also AI, you can do videos. So in a matter of seconds, you can put together, instead of a very, very long text, you can put together a video that say probably more than many, many words. And then lastly, I want to express excitement about what AI could do. It's more my role as a mom. 3 years ago, I delivered a baby and I had a very, very rare disease. Not very, very rare, but I had postpartum preeclampsia. Postpartum, meaning after giving birth. I wish that AI was there and then the doctors could predict through predictive analytics that they wouldn't have released me from the hospital. Because you know what? They released me way, way too soon for then having me to come back to the hospital for two more weeks. I was separated from my baby, my milk production went down, and I started motherhood as a traumatized patient or mom. Given the maternal morbidity and mortality in the US, I don't wish that to ever happen to no woman. That's not a good way to start your motherhood. So all this to say that predictive analytics, if we can use it for patients and for women, especially well for mom, given how the US is showing maternal morbidity, it can have a tremendous impact. So I am here to say that I'm very, very excited about what AI can do for global health, for students, and for moms.
Thank you so much, Solange. So, I mean, what we're hearing here is that the application of AI is broad and is wide, and there are so many opportunities. And that really brings me to this next question that I have for you, Jason. You have an interest specifically in leveraging large language models to integrate social determinants of health and the data specifically into electronic health records. I wonder what your thoughts are or your concerns about how this kind of integration into AI in healthcare may create or exacerbate these issues, like these disparate outcomes in maternal health or other health disparities that exist. And also in terms of like how it may impact access to healthcare.
Thank you. So first, I just want to talk about the pros before we get to the cons, right? And so I think the important thing about generative AI and large language models, as well as machine learning techniques, is that it has the potential and has shown through research to identify gaps in research that we haven't necessarily found just by using regular predictive analytics as humans, right? And so I think the important thing in AI is that it allows us to identify where these health disparities are, so then we can help increase policy and implement policy that allows stakeholders and physicians and clinicians, as well as clinical researchers, to work on increasing the amount of data that's available in order to scale these models at large. And so on the flip side, a lot of the harm that can be done using these models all lies in the data that we have available currently. And a lot of the data that we have is biased. Historically, there's racism in medicine that has led to a lot of harm for Black communities I'm a part of, as well as other communities. And that data is lied in the training that physicians, medical students actually go through. And so alongside with that data, there's also when physicians meet the patients, there's also unconscious as well as conscious bias that can also lead to the input of social determinants of health and making it more reported by the physicians rather than it being self-reported by patients. And that leads to a lot of bias and potential harm in these outputs of these generative models, because if we don't have the data that can, if we don't have the right data that can automatically target these health disparities and how to fix and reduce these health disparities, then instead it will cause more harm and exacerbate these disparities. For example, Google Gemini released their generative AI model a week or two ago, as well as everyone knows about ChatGPT. And so these are two good examples to explain. So in ChatGPT, it was a few months ago, I inputted just a query, just a prompt engineering query to see exactly what would I get. And I typed in, please show me an image of a Black man who is a medical physician in a healthcare system. And what it actually spit out was a white person, right? And we know that that's not what we put inside this model. And so that there shows that there's already bias in the data that's being fed into the model that then exacerbates more disparities as well. And this aligns within the healthcare system as well. And on the flip side, Google Gemini released their model maybe like a month ago. I don't know exactly when. And I saw this on Twitter, and there was a Twitter feed about a few pictures, and someone typed in a picture of, said, please show me what Elon Musk looks like. And Elon Musk actually came out as a Black man, had the same features as Elon Musk, but he was Black. And so on the flip side, you have one that's shown a lot of stereotypes, and then you have one that's shown an overcorrection of diversity. And so what's important in the healthcare setting is that we also include diversity and equity within the data that we're feeding into these models, as well as we're also understanding the potential harm that can be output, so we can find a middle ground. Because then when we find that middle ground, that then will be when we be able to reduce some of these health disparities while using this technology.
Thank you, Jason. And you said something in there that made me think about the question I'm going to ask you. It's just like, what happens when the person taking the clinical note or the medical history doesn't put everything into the note? And that's what we're training the AI on. And so, Dr. Sushil, your expertise is in developing these large language models, specifically for EHR, electronic health records. And you have a special interest in using the textual EHR, so the narrative notes, the images, and specifically to kind of try to figure out and understand when diseases are going to occur. I wonder how you feel AI might impact that patient-provider relationship, and what concerns for potential of loss of human interaction that may arise.
Thank you for that question. Thank you for that question. I think it's very important to think about these problems as we are developing and considering applying these tools within healthcare settings. When I think about the use of AI technology within clinical decision support systems, there are two aspects that I think are extremely important to think about. One is the data that it is trained on. As Jason has already discussed before, it is very important to make sure that the data that you're feeding to these systems are appropriately diverse so that they do not learn the encoded biases. And also, it is very important to ensure that the training mechanism for these systems do not further propagate the biases that are coming from data. And if we are training them to mitigate these biases, they do not over mitigate the biases. So it's a very difficult balance to strike. So I think it's extremely important to test out these systems extensively before use and ensure that they are validated on the use case that are going to be used in practice. So they need to be validated for every specific use case individually before they are deployed, so that it might not, or we can at least reduce the negative impact of the use of technology in real world settings. Now, I'm very hopeful still about the impact that technology can have, and we have already discussed some of it before. So while we are discussing on the perspective of how it might reduce provider interaction, I'm hopeful that it might increase provider interaction between patients and providers. We are seeing a lot of technology is being piloted, for example, to take automatic notes in the clinic when we visit a provider. Currently, what happens is when we go into a clinic, the provider is usually busy documenting what they are talking to us about, and there's little interaction that happens between the patient and the provider. By automating some of the processes, like automatically documenting whatever interactions are happening, automatically potentially summarizing these cases, I am hopeful that we can increase the time that the provider can spend talking to the patient and understanding their true histories. Other than that, we have been seeing cases, for example, for automatic summary of generation or automatic replies to patients when a patient is sending a question to a provider. Now, given that they are all very time constrained, I think I have a lot of hope that when you are given a draft, you can edit the draft at relatively faster pace than you would write a message up front. And there have been some studies that have shown that automated replies can be more empathetic than a provider would probably think about writing themselves because they don't have time. So while there is a lot of potential for harm and we need to really validate these systems extensively before use in very diverse community, very diverse settings, I am hopeful that it might increase our interaction with the healthcare system rather than to reduce it.
Thank you, Dr. Sushila. So I wonder, we have people who are in data science here. We have people who are in advocacy. I wonder if either Luis or Solange or even you, Jason, have any response to that question, because we do have a few more minutes.
Going back on to what Madamita said, I think that it's important to increase the diversity, like she said, the diversity of the data that we're feeding into these systems. Recently, back in fall 2023, the White House Office of Science and Technology and Policy, they implemented this social determinants of health playbook. And before this time, social determinants, they were a voluntary task to, they were voluntary for clinicians to input in a patient's document. But now they made it mandatory that all patients who are on Medicare to actually, for their social determinants of health information to be inputted as of this past January, that just passed. And so I think just increasing the amount of social determinants data that we're feeding into these models now that we have access to this data in both the clinical notes, both unstructured as well as the structured database that we have here in the UC Health System, I think that can lead to increasing the amount of diversity of thought as well as what these generative models are outputting. And then on top of that, just to add one last thing too, I think it's also important that as we're understanding these generative outputs and what they're actually producing, that it's important to recruit a diverse set of clinical annotators to annotate these generative prompts to ensure for its accuracy for specific disease such as diabetes or any disease use case that might be important to the research study.
Thank you so much. This talk of the data that we want to capture makes me think about you, Luis, in the next question. But I also just want to point out that today, for our original goal for this panel was to actually bring in community members external from the University of California. But what we learned is that when we reach out to community, there are not really a lot of folks out there who feel confident in having this conversation. They don't feel like they have the knowledge or the expertise to meaningfully contribute. And that brings me to Luis. We have heard how we envision AI enhancing our understanding of disease and its potential for connecting the dots that we can't see. And these are the hopes and the dreams of researchers. I wonder, what do we think the hopes and dreams of our community members are in terms of AI and healthcare? And in what ways would you like to see community members more involved in the development and the deployment of these technologies?
Great, thank you. Well, I'm going to start off with a little game. It's going to come back around to the answer to this. So we're going to just pretend that in this room, we are all of the knowledge and all of the data for a new AI system, a new AI program, right? We're going to be using this within a healthcare setting. I'd like people to just shout out, how many genders are there? 5, okay. What else we got? Expansive, that's another one. Y'all, I know you have, it's the morning, but there's coffee over there. What else do we think? How many genders are there? 7. Infinite. I don't know, there's not really a right answer. There's a wrong answer for sure, in my opinion, but there's not really a right answer. Okay, so we've got numbers between 5 to infinite, right? So that this is our AI system. How many sexes are there? I'm getting crickets here. How many sexes are there? I'm not gonna, again, I think that there might be a wrong answer, but there's not really a right one. More than 2. More than 2? Okay, what else do we have? All right, more than 2. I'm gonna say, maybe some people in here think that there's 2, right? Depending on the type of data that we're pulling from, like my colleagues have been sharing, that's really going to impact whatever the program is. And how is it that we ensure that this data that we're getting is going to accurately reflect the lived experiences of community members, the lived experiences of people who are placed at greater risk for all of the health disparities because of the structural inequality within society? And what is the role of community in terms of informing the development of AI technology and informing how we validate where we're pulling this data from, right? If we've got AI data that's telling us that there are only 2 sexes, and we have an intersex person who's presenting at the hospital for something that may be related to some hormonal issue that they might be having, and maybe their intersex identity or condition, or however they describe it, is also related to some variation in their hormones. What's going to happen with this AI system? Is this AI system then going to be tied to how this individual is able to access care, or whether or not they are able to proceed on to being able to see a clinician, right? If we've got a trans or a non-binary person who is presenting and who has an issue, my hope was that with AI, we could theoretically avoid some of the biases that we continually see for not just LGBT folks, also, all BIPOC patients, that we could avoid some of that bias. But the bias, as we've been talking about, is baked into the system, right? It's not like appearing within this one clinician who is treating me horribly within the emergency room, right? Because of their own internal bias. It's baked into this data. And so when we're thinking about these generative AI systems, there are several examples of community-based, community-informed systems that have been used. There's, my world is within HIV. So there's several PrEP models that have been used. PrEP is it's either a daily pill or an injection that can prevent HIV acquisition. And there are models that have been used, for example, in Brazil. There's a model that was developed that is actually kind of like an avatar-ish sort of system. The generative AI model is a Black transgender woman who talks with other Black trans women about PrEP use, uptaking PrEP. The Trevor Project, which is a national hotline for LGBTQ youth, also has a generative AI model that is being used to train the volunteers on this hotline. And so there's a lot of room for the ways that community can inform how these models are created, where we're pulling this data from. And I also just want to say that, AI terrifies me and gives me hope, just as many things in the world right now do. But right now we have 478 anti-LGBT laws that are currently winding their way through various states within the United States. We're in March, 3 months into this year. The vast majority of these are anti-transgender potential laws that will be taking away, a lot of it is medical rights, right? A lot of it is access to medical care. How are these laws going to then inform our AI models that we'll be using? And what is the role of which communities that we're listening to? Because I know which communities I don't want to listen to, and I know who I do want to prioritize and who I do want to listen to and who I do want to have input. I think that's my time.
Thank you, thank you, thank you. That was very rich. But one question I didn't hear, and that's so, no, it's okay. I want to actually hear, I'm going to tell you the question now, but I think that we're going to come back to it. What I want to hear is, what do we think that the communities that we come from, maybe like right now we all represent UCSF. We're researchers, we're educators, we're out in the community, but we come from someplace. So I'm going to pose it now, you can marinate on it. What do you think the hopes and dreams are of AI for your community? Pause, marinate, and then I'm gonna bring my next question to Dr. Sushil. With the increasing use of AI in healthcare, we're switching gears here. We're talking about privacy. What do you think the concerns are? I mean, we've talked about, we're hearing a lot of issues, right? Imaging, SOGI data, maybe they ask, maybe they don't. The models are going to transcribe what they're hearing in the clinical visit. What do we think about health data and privacy?
I think this is an extremely important question to think about. And this is something I think about every day as I develop and I use these models. So some of my thoughts here. I think it is important to have diverse data sets, as we have discussed before, to ensure that we do not propagate any unnecessary biases in these systems. But the more data we add, the more we put the data at risk for privacy, and we might end up compromising individuals if we are not careful about how we use this data. So I think it's extremely important to ensure that every data that has been shared, every piece of data that is ever used for training these models is stored. First and foremost, it's stored in very private and secure environments that cannot be accessed easily. It is important to ensure that these systems cannot be hacked easily. We have been seeing more cybersecurity related concerns recently. So it is very important to ensure that this data stays with access to the very few or minimal set of people who can interact with it. Now, while it is important to use that data in development, I think one very good way is to de-identify the data before any further use. UCSF has been doing an extremely good work here, and I think it's extremely important to trust the de-identification process that is used to de-identify the data as well. So even if the accuracy is 98%, that 92% difference might be critical enough to not be good enough. So it's very important to ensure that the de-identification processes that are used are robust, hopefully certified by an external agency that specializes in ensuring that data has been de-identified correctly, and ensure that that is the data that is used in developing these systems. Now, why I think that it is important to de-identify the data, because at least I can talk from the perspective of generative models, which can be either large language models or image models or video models or similar. And these generative models, how they're trained is to predict the next context given the current context. Now, when you're just generating the data, even if it generates one relevant private piece of information, that can be compromised. We have seen that although some of the corporate companies are putting railguards in place so that people cannot query for private data, it is very easy to break these systems currently. It is possible currently to have adversarial attacks that let the data out in the open. So personally, I think if we are developing these systems, it is important to use de-identified data sets. Now, that is for the systems that are developed. Now, what about just using some of the existing systems? How do we communicate with private data in those systems? For example, if they will be integrated within healthcare settings. Again, there are multiple things that need to be taken into account for this. First and foremost, it is very important to understand, one, which AI models or systems are being used, and two, how are they being used? So it is possible to either use one of the open source platforms that have been validated by the open source community, or it is possible to use one of the proprietary systems. It is fine either way. The choice is fine, but you need to make sure that when the data is communicated to any of these systems, either it is done on-premise using the open source systems, or if the data is being communicated with a third party, like, for example, one of the providers of these language models, then it is done so in a secure environment, in a setup where the data is not transferred to those systems, but it is just like giving the outputs without storing any data on their end. This is very important to ensure that whatever data is passed can be used with our knowledge. Like, they cannot be used without our knowledge for the purpose they are being used. So I think that is also extremely important, and all of these concerns are really needed before any systems are developed on this and any systems are put in place to use the data. I hope that answers your question.
No, it did. Thank you very much. I'm going to kind of veer a little bit into the space of this next question, which is for you, Jason. What would increase the trust? So we're kind of shifting from this safety to trust. What do you think would increase community trust, patient trust in AI systems used for healthcare purposes?
So I think the first thing is to create a culture of openness around AI, right? Of course, everyone in this room is somewhat familiar with AI. They've used ChatGPT, but out in the real world, there is a high percentage of individuals who are either afraid of AI or don't know what AI is, or hasn't even had a chance to interact with an AI platform or any sort of user interface that uses AI, right? So in order to increase trust from patients, and in order to increase trust from health systems outside of leading hospital institutions such as ours, we need to create that culture of openness, right? And then on top of that, we need to be transparent in how we communicate how we're using this data that we're getting from patients, and how we intend on using this data for research purposes, as well as being transparent in the way we communicate our results back to the community. I think that is one of the two most important causes of increasing trust in AI and increasing the ability for patients and people from especially underrepresented communities to participate and be willing to use these sort of new technologies that is out here today.
Thank you. Yes, actually, I want to hear from you.
I would also, this question makes me think about during the COVID pandemic, when we had the most important tool to save lives, it was vaccination. And I feel like we are at a similar place in time right now. We had the vaccine, and then the uptake was very low, even though it was proven that it was safe, it could save life, hospitalizations, and all of that. And I think that part of the problem was that the language that was used to communicate was not in a way that the community could understand. Well, why was it so fast? What is an mRNA? What is all that? So I think that very important message for the AI community is that we have to use plain language. As a matter of fact, I'm going to be transparent with you. Part of the things that she was talking about, they were very foreign to me. Natural processing language. What the heck is that? And I feel that if Solange Madrid, doing a doctoral program at UC Berkeley, don't understand, the likelihood that even in this room, there are people that don't understand what that is. And if that's the case, then even more people in the community. So for me, in order to make AI understandable, we have to use plain language. And also, I'm thinking as we couldn't think about a research project without the participation and the partnership of community members At UCSF, that's right now, I would think that that's unthinkable. Like we could not do research without partnership with community members. It's the same thing for me with AI. We cannot think about serving the community without not only like their input. It's not input. We want to collaborate, to co-create, and something that to me would increase trust. Well, first of all, is seeing more women in their board of directors, seeing also people that speak like me. I'm not English. English is not my first language. So seeing people that English is not necessarily the primary language, that make mistakes when they speak, and all other things like that. So I think that my messages here is we need plain language. We need people that can say it how anybody can understand. And also transparency, as Jason was saying, and seeing in the people that are working with them, more faces. We don't want to make the mistake of, I don't want to say what, but we need different faces, different genders, sexes, also to make Luis happy too. We need that. We need diversity. And so plain language, diversity.
Thank you, Solange. And I want to hear from everyone. So, I mean, the same question for you, Luis. You got it.
Yeah. I think so for trans and non-binary communities, and I'm mostly steeped within Latina trans and non-binary communities. My friends aren't really talking about AI, right? My friends, my community members are talking about how they're going to get their next paycheck, how they're going to survive, right? How folks are going to be able to afford to pay their cell phone bill or to feed themselves at the end of the month, right? I think that's where my community is at. And there's a huge opportunity for us to be able to have input within the development of these systems, within the development of these programs. Just even thinking about like facial recognition within AI and the immense ways in which that can harm trans and non-binary communities. If you think about what if there's facial recognition going into restrooms, right? And you're only allowed into the restroom if you look like whatever gender it is that you supposedly might be. There's conversations being had in certain states about this might be a good use of this type of technology. Being able to have that input, I think is going to be very beneficial. But again, it's which communities are invited, which communities, even within this room, if we needed to reach out to trans, non-binary, and intersex people to give input onto our own internal programs. How many of us in this room know of people who we could call upon, know of community members who we can call upon to be able to have that input? So it's also about us. I don't know what you all are doing, but if you're doing AI work, being able to have these connections to community members and to communities who are disproportionately impacted by all of the health disparities.
Yes, and so again, the question is about data and trust, right? What?
I don't know. Did I answer the wrong
You
question?
answered the question beautifully. No, but you got to the point. It's about how can we make AI just more trustworthy? And I would love to hear from you also, Dr. Sushil.
I think it is also important for the community to be involved in setting up the guidelines for use of these AI systems to inform policy level changes. Currently, we see that not much, we don't have a lot of legal basis around use of AI. Policies are still in flux. People are informing the policies, figuring out how to best use these systems. So I think it's very important for everyone to speak up. How is it okay to use these systems? What uses are not okay? And just to establish general guidelines around the ethical and legal use of these systems.
Thank you. And for the final question, which is kind of an extension of the conversation we just had, what are your hopes and dreams? If you go back to your community, not your UCSF community in this instance, but where you come from, what do you think people would like to see AI used for within a healthcare setting to really move towards achieving health equity?
I actually had the experience that Dr. Sushil was talking about. When I was in the doctor's office, she was looking to me in the eyes for the first time, instead of being like, for like 15 minutes. And that's what I desire for the Hispanic community. And what I desire is compassion, compassionate care, which I know that that's what at the heart of doctors here. But because they're so burdened in so many other things that they have to do and keep the records and all of this stuff, that's what I want. I want people who necessarily that English is not their first language, to have that compassionate care. And I do want to believe that AI can have an impact there.
Thank you. Here, go ahead. Yeah, we'll just go down the line.
Yeah, I can add 3 things here. I'm thinking from 3 different communities here. One is for rare diseases. So a lot of these systems are trained on data that is found on the internet or found in health systems at best. Rare disease patients are not represented well in these data sets, and by definition, they won't be represented well. So it is highly likely that a lot of these systems might might make it worse for the rare disease patients. But if we are mindful and if we develop these technology to help these same diseases, then it is, I think there is promise to improve rare disease cases as well. So we know that diagnosing rare diseases is extremely challenging because practitioners don't have a lot of experience with these cases. Now, if we can develop these AI systems in a targeted manner to identify rare disease cases more proactively and maybe nudge the practitioner that the patient coming in might be suffering from one, I think there's promise to improve care for these patients and reduce the burden, the emotional and financial burden that patients face because of these diseases. My second perspective is from diversity. There was a very famous study from UC Berkeley that I'm a big fan of, and that was trying to use AI systems to explain some of the disparities that are observed in real-world settings in pain scores. But clinically, these disparities are not explained using the current systems because the systems are not designed to cater for diverse populations. So what this study did is use scans from a diverse population and tried to predict the scores directly based on the intensity of pain that they see using the scans. And they could explain more disparity there than any of the existing medical systems could. So I'm very hopeful that AI can help understand medicine better, especially for diverse groups that are still understudied. And for me, the third community that I strongly feel a part of is the global community. While we have a lot of access to good healthcare in the United States, it is not true for a lot of developing countries in the world. We don't have systems that have, for example, as high quality imaging. We don't have expertise. We don't have high quality ultrasounds for maternal care. There are many different issues that affect these populations. And I think it is important to develop AI systems to build solutions for those communities. And I'm excited to see that that is already happening. For example, low quality ultrasound images are being used to generate higher quality equivalent ultrasounds and used for identifying maternal care related conditions in some parts of Africa. So I'm hopeful that these technologies can scale healthcare and expertise as we see in the United States at institutes like UCSF at a global scale.
Thank you. Jason?
Can you repeat the question? I just want to make sure I don't miss anything.
No, and basically, like, if you take yourself out of your UCSF hat, put yourself in your community hat, what do you think the hopes and dreams are for AI in terms of healthcare and equity and outcomes and access?
I think the first hope and dreams would be, one, as we continue to trust in this technology, specifically for the Black community, is to hope that AI improves clinical decision support tools, as meaning tools that we use to identify and diagnose diseases, as well as identify solutions and treatments to treat these diseases. I think that's first and foremost. And I think the second thing that I hope that AI can really do a really good job at is increasing the comfortability of wanting to see a physician for any and everything instead of just going when there's a major life-threatening solution or a major solution that we can't fix at home. And I think that AI also has the advantage to improve early early screening for diseases such as cancer and other diseases that I think can ultimately save more lives if we first increase the comfortability of people who are in my community to want to go to the hospital earlier, as well as improve the clinical decision support tools to increase the effectiveness of diagnosing diseases that mostly affect our community.
Thank you. And we'll end with you, Luis.
Excellent. Y'all are lucky. I think that my hope is that AI could work to dismantle the stigma that is embedded within a lot of our medical systems. I'm not sure how easily that will occur, but if we could have AI work, if we could get AI to dismantle white supremacy, I feel like all of our lives would be improved, right? If we could get AI to help dismantle poverty, I don't know, maybe it could happen. Y'all, if anybody's a program in here and figures that one out, good for you. You probably won't make any money off of it, but that's my hope, that it can just dismantle some of the stigma that people encounter within clinical settings, so that people could just have a clinical encounter and get the care that they need without all of the BS that we have to go through, that we have to experience, that just worsens our health outcomes.
Thank you all. I just want to thank you all for joining us today. What I'm hearing is that there is immense potential for growth in terms of this industry, and specifically in how we can really tap it to benefit patients and the healthcare that they receive, the interactions with patients and providers. And I'm also hearing that we should be optimistically cautious, right? That this foundational knowledge that we're building systems upon is coming out of a society that has built-in bias from the beginning, and that we have to be mindful of that, and bring folks in to really help call out the gaps. And in closing, we all know that we use data and AI, and that AI has gaps, and that the scientific community is really doing an impressive job of coming together. But what we're noticing, and what I'm hearing, and what I experienced firsthand, is that we're maybe not doing the best job of pulling community in. I'm hearing a lot about how we can build trust, a lot about how our community members may vision for the use of AI in healthcare, and I'm not necessarily hearing those same conversations within the healthcare and science space. So my hope is that as a research community, I've heard a lot about community collaboration across the institution. And I hear about ethicists, and I hear about bioscientists, and I hear about health equity people, and I hear about health system people, but I don't hear community members. I don't, and what do we mean by community members? I don't hear about patients being invited to the table. We don't hear about patient advocates, folks who are working within the community health setting, within our community health consortiums. And I think if we don't bring them to the table, it's a missed opportunity to really create this, to really enhance the foundational knowledge, really to like point the AI in the direction, because we want to feed it what we need it to have to really help us all achieve that goal, which is equity, and increasing access and reducing poor outcomes. So I want to thank you all for being here today. I want to thank you all for joining us and sharing your diverse opinions. And with that, we're going to pass it on. So thank you so much.
And right there. Let's make sure.
Thanks. Hi, everyone. It is my pleasure to welcome our next speaker to the stage. Dr. Alicia Fernandez is Professor of Medicine and a General Internist at ZSFG and Associate Dean of Population Health and Health Equity for the School of Medicine.
Thank you.
Thank you.
Thank you, everyone. And thank you to the panelists who bravely and generously shared their views. And thank you very much for that. Hello, happy International Women's Day. International Women's Day started in 1857, came out of sort of the European socialist unions, but based on some events marches that had happened in the United States. And it was celebrated for a while with varying degrees of success until the events of March 1911. Does anyone know what that was? It was a historic day, and New Yorkers won't recall, but will recognize what I'm talking about, which is the Triangle Shirtwaist Fire. A terrible fire in the Triangle building in New York City that you still see, looks like a triangle, where there was a factory of women who sewed and made garments for the nearby garment district. 146 women died, jumping out of windows and burning to death. And out of that came International Women's Day, a gift of the United States to the world, and also the International Ladies Garment Workers Union. These 146 women, does anyone know how to describe them, who they were? They were immigrants from Eastern Europe and from Southern Europe. And then, like now, immigrants continue to do these very difficult, often very dangerous jobs. And I think we all had a wonderful, a clear example of that during COVID. So again, congratulations to the United States for giving the world International Women's Day. Let us celebrate that. And at the same time, remember the lessons of those women and what they teach us. I listened to the panel with a lot of interest. And I've been at different places where people have asked about the associations between AI and health equity. And I was glad to hear the panel mainly avoiding what I call the Deus ex machina solution. It is a Greek play. The situation is terrible. There is tension on all things. It cannot be resolved. Fortunately, in the fifth and final act, the crane lowers a god who puts everything to rights. AI will not do that. I am sorry. But it is useful to think of it more. And I've been in health equity meetings where that's been the sense. It is much more useful to think of it as a tool. A knife, murderous in one hand, a vegetable chopper for my risotto in another, or a scalpel, healing. But at the same time, new tools offer new possibilities, and those are tremendously exciting. And I am so excited about that, and so excited to see particularly the advances that we will have in science, in healing, in so many ways, and the ones that I can't even imagine. But I think that that while extraordinarily exciting, it will be like the knife, what we make of it. And that will require vision, thoughtful dialogue, and a commitment to equity. And I can't think of anyone better to start off this discussion than my wonderful long-term colleague, Dr. Kirsten Bibbins-Domingo, a product of UCSF. She has been in a beacon as a researcher as a teacher, and as a clinician. And we missed you in clinic yesterday, where she continues to participate, precepting at San Francisco General. She is, of course, the current editor-in-chief at JAMA and the JAMA Network, but continues to be very close with all of us here. Kirsten, thank you in advance, and I will prepare the gods to come down and solve the problems.
Awesome. Thank you for that very nice introduction and for the invitation to join you all here for this important meeting. And I'm so glad that I learned how we got International Women's Day. That's wonderful. I have a few reflections for you all to consider regarding data, regarding equity, regarding how we think about research, and putting that in the context of what is this really incredibly energetic interest in artificial intelligence. So I have 5 reflections here, and hopefully we can talk about them again, because I know we'll have a panel right afterwards. So the first one is just to be clear. We have done a remarkably poor job at ensuring that we have representation in clinical research. So this is something that was made clear to me in a very striking way by a committee that I chaired during the pandemic for the National Academies. This committee was focused on improving representation in clinical trials and clinical research. It was focused particularly on those groups by race or ethnicity who've been historically underrepresented and women. And I want to start with the 7 reasons that this committee identified as why representation matters. The first is that it's just good science. That when we have representation, when we have lack of representation, it compromises our ability to generalize findings that we have in a research setting to the entire US population. And we were focused here on the US population, but I'll make the broader global points as we go. Lack of representation may hinder innovation. We risk missing on important discoveries that we might find in populations that we're not focused on. And diversity in terms of participation has always been associated with increased innovation in science. And lack of representation is important because, very strikingly, about half of the studies that are funded by the NIH don't actually get enough participants to be enrolled in those studies. And so if we are going through life looking only in one place for participation and not in others, we're actually contributing to the reason that many of particularly trials in the US actually fail. Representation is important for clinical care. So lack of representation is important because participation in studies is oftentimes the way people have access to new therapeutics, to new drugs. They're studied first in a study setting. Cancer is most notable for this. And so lack of attention to making sure that participation in trials is available to everyone in the community might actually mean lack of access to medical interventions. It also happens downstream because sometimes we make drug approvals, we make guidelines just based on who's studied. And because we don't know whether something is effective in younger people, in pregnant women, in other types of populations based on characteristics, we sometimes create guidelines that actually so narrowly tailor that we actually are, in the end, depriving people of interventions that might actually be effective. And finally, in this section for clinical care, it undermines trust. And what the last panelist, someone mentioned the issues with our vaccines. And I think we saw the issue of the vaccines where we had actually different communities saying, well, did you study this in my community? Did you study this in people like me? And those are things that are important for really thinking about the implementation, even after we get a result, that more and more we have people saying, well, who did you study this in? And so if people don't trust an intervention, they are not likely to take up that intervention. And so this may contribute. But most importantly, representation is important for health equity. And you know, we have big gaps in equitable access and in outcomes. In the US, we have them across the globe. When we are not studying the issues related to these gaps in care, gaps in outcomes, we are in fact, by definition, contributing to those. And that those disparities themselves cost in the US billions. So this is a study we published in JAMA last year. It's led by Tom Leviste. Eliseo Perez-Estable is a former faculty member here at UCSF and the director of the Institute for Minority Health and Health Disparities. And they basically quantified the economic burden of racial, ethnic, and educational inequalities in the US. And this total is approaching 1 trillion. Now, there's a lot of reasons that research is not the solution to this problem, right? We all know that. But if research and focused attention from a health perspective was just a very small fraction of this, the cost of not really having that focus is actually quite immense. So given that there are a lot of great reasons to do this, how are we doing? It turns out that there have been 3 decades of commitments, stated commitments on the part of the NIH, the FDA, Congress, other types of agencies saying representation is important in clinical research. We have largely stagnated. We have not made any progress over about 3 decades. The numbers are almost identical. The exception here is women. Women now represent over 50% of, at least in this case, trial participation in the US, but in particular groups, pregnant and lactating people, sexual and gender minority populations, and in racial and ethnic subgroups of women, they're still underrepresented. And perhaps most concerning to this committee was that the data to monitor progress is not there, right? And so there's not an easy way for us to say, oh, last year we did this and now we're doing better. So this was a real issue that I think this report spoke to, and I think drew the attention at the FDA and at the NIH on this important problem. So here's an important point, and you all know this because many of you are engaged in this type of work. While unwillingness to participate in clinical research is frequently cited as the problem, those populations who are underrepresented are no less likely to participate in clinical research if asked. And this is a really important statement. It's really borne out by the evidence, and I think is really critical for us to continue to remember as we talk about this. Often, populations are not asked, communities are not asked, and they're not asked in a way that is effective for the goals that we have. It is true that there is distrust and there is mistrust, and that matters. But in most cases, these are not insurmountable barriers. These are not things that we can't overcome. And we had the good fortune in this group for interviewing many highly successful research groups who've really invested in engaging with communities, in figuring out how to overcome these. And I think that is clear. So we've done a poor job. We just have to accept that that's what it is. The challenge for us now is that we have this big, extraordinary interest in AI. And AI, basically, at its heart, is taking all the data we have out there and is making it really efficient for us to use that data to make decisions in practice, to make decisions in policy, to make decisions to give you back information when you ask questions in a chatbot. And when you have algorithms that are built on data that's poorly representative, that is itself a problem, right? And it's not only a problem because we don't represent all people, all communities in the data that's there. It's also true that, that the patterns of our historical discrimination, bias, racism, it is actually encoded in the data that exists and risks coming out in clinical practice, further worsening disparities. There are a few good examples of this that I just like to highlight. This is what our information on genetic studies, where it comes from. This was published in Nature, and you can see here the vast majority of our genetics research comes from people of European ancestry. And even though there has been an explosion in the types of genetic research that's done, as you can see here, just by the quantity of data, it comes really remarkably and disproportionately from those of European descent. Does it matter? Well, this is what polygenic risk scores look like when you apply current information on polygenic risk scores and predictive accuracy in the different populations. So this is just one example, but it's a clear example of what we see has an impact on how well tools that are developed using this information perform in different groups. And the challenge now, of course, is that with the computational speed and the ability to integrate data from multiple sources into clinical practice in the electronic health record, in online tools to help you assess risk, this risks being magnified, right? Unless we pay attention to it. There are other good examples of this. This is from Ziad Obermeyer at Berkeley, and many will know this study. So Ziad studied a tool that had been developed to help clinicians refer patients with chronic illness to care management. But the tool was trained on historic patterns of use. Who did physicians refer for chronic case management? And what he showed here basically was that if you look on the left-hand side of the screen, you can see by Black and by white patients here, the percentile risk score, that is the number of chronic illnesses that they have and the likelihood, the chronic illnesses that they have, which should be related to their likelihood of being referred. And what you can see on the right, you see that same simulation. This is now just for Black patients. As you have more risk, you should be more likely to be referred. And actually the algorithm only refers at this lower line, right? Because the algorithm is basically trained on what did clinicians actually do? And in the reality, the data set that was used to train this algorithm here is that it was that clinicians were not referring Black patients at the same rate as white patients based just on clinical risk. And the algorithm learned that. And so the algorithm now tells you when you're in practice, oh yeah, this patient you should refer for this. And he showed this very nicely. He has a very nice follow-ups on how they got this algorithm to be changed. But this is another example of the challenges, not just of not having the types of data, but also the ability to interpret the data based on historical practices that are inequitable themselves. Okay, so here's one that I had not quite considered as much, but I think it's worth us stopping to think about. Many people talk, when they talk about or write about AI, they talk about automation bias. And automation bias is this idea is that you and I are just going to believe things because the computer tells us. And we all think we're not going to do that because we're smarter than that. And, we know that these patterns are biased and we should, for the things that we're expert in, we should trust those things. Well, this is a study that I like. And I had the good fortune to talk with one of the authors recently about this study. This is a study not about equity, not about race, ethnicity, but it is about automation bias, right? This is a study about chest x-rays and whether we can diagnose whether somebody has pneumonia or heart failure or pulmonary edema. I put the study in there for our dean, who's a pulmonologist. He, of course, would not have a problem with this study. But for the average clinician, we're about 75% accurate at being able to look at a chest x-ray and say, oh, that's pulmonary edema or pneumonia within a clinical context. What these investigators did was they basically said, if we have a good algorithm that helps clinicians in their decision-making, will clinicians get better? And it turns out they will. So they made a really great algorithm. They trained it well, and clinicians moved from by 75% accuracy to about 82, 83, right? So now they said, computers take shortcuts. And an example of a shortcut would be a computer will look at leads that shows you have a pacemaker
And they say pacemaker means more likely to have heart failure. And so therefore, they won't look at what the lung fields are, but they'll say, yeah, it's probably heart failure, right? Because the pacer is a shortcut that whatever we see on the lung field is heart failure, right? Even if, you know, a clinician would look and say, well, that doesn't look like heart failure, it looks like pneumonia, right? So what they did now is to create essentially bad algorithms that are not that good at doing what they're supposed to do. And they asked the clinicians, they did the same thing. They asked the clinicians, what do you think is diagnosis here? Here's what the computer tells you. Does that change your mind? And then they also said, well, would it matter if you knew that the computer is actually just looking at the breastbone, or the computer's looking at the pacer leads, not really looking at the lung fields? So here's the bad news. So when they gave them the bad algorithms, clinicians became worse at interpreting chest x-rays. So we're at 75%, now we're worse. And telling us that the computer is looking at the breastbone or the computer is looking at the pacer leads, not at the lung fields, didn't help. It didn't help improve the accuracy. So think about this for a second. I'm at 75%, I'm pretty good, but I'm now substituting the judgment, right, from the computer. And that is automation bias. And that is a very real thing. And I have heard about this from, you know, the people I've had the good fortune to interview about AI. But I interviewed a Princeton professor who said, this is in fact one of the biggest problems when it comes to equity, because we have the opportunity to talk with each other, to think about how we train people early in practice to think about the decisions they make in the context of the patient that they have in front of them. But if we have a world where we actually substitute our judgment for that of the computer, and we are not even able to write that judgment based on tools that help us to think better about whether the computer is telling us the right answer, that's not a great thing. All right, so what does this mean? Now, I will tell you, I'm very optimistic about this technology. And I think one of my take home for you all here is, I think there are so many reasons for us to be skeptical based on the first three things I've told you, for us to want to be protective of the patients, of the communities that we're talking about. Thank you so much. But I think we also have to recognize the potential power of these technologies, because that is important for the patients and communities we care about as well. So this is a piece that was authored by Bob Wachter, who's the chair of medicine here, and asks whether generative AI will deliver on its promise in healthcare. And this is one of the parts in this article that I really like. He says, we expect Gen AI will notch its early wins in healthcare delivery systems, not so much by handling patient-facing tasks, such as making diagnosis and recommendations, but addressing areas of waste and administrative friction, whether in creating a physician note, scheduling an appointment, or sending a prior auth requested to an insurance company. And as Alicia said, I work in the same healthcare system she does at San Francisco General Hospital, and the opportunities for improving those things that are hard to do in less well-resourced settings are ones that we shouldn't ignore in this environment. In fact, we should figure out a way for those types of technologies to help in settings where these issues of friction and calling to get the prior auth are exactly one of the main reasons that patients experience barriers in access to care. Here's another way that people talk about this. This is also from one of your UCSF colleagues, Atul Butte, who talks about this term scalable privilege. And he wrote about this in an editorial for JAMA Oncology. And he says the real potential for LLMs and AI to be trained from the patient clinical and outcomes data from the best centers to deliver the best care through digital tools to all patients, including those who don't necessarily have the resources or privilege to get that level of care. There is no doubt that AI and LLMs are not yet perfect. They carry biases that need to be addressed. But this should not alter the potential for how these can improve care for both the haves and the have-nots of healthcare. He says it's time to stop thinking of AI as nice to have pilots and realizing the opportunity for AI to be an opportunity for scalable privilege is what he talks about. And he talks about this in a variety of ways. And I've heard many, and there are many faculty who are very interested in this idea of being able to reach patients and communities who we've not been able to reach well, for them to have the same opportunity for, the reads for certain types of diagnostic tests that really require specialized reading, and being able to do that in a way that makes healthcare more accessible. Atul talks about this in a nice podcast that I think it really brings it all home in a very nice way. I had the opportunity to speak at the Department of Medicine retreat a few weeks ago, and I actually heard some really nice work being done at San Francisco General on looking at heart failure readmissions data and using AI algorithms to help in readmissions data. And it was a good example of a system that is more resource limited, outstanding committed faculty, but then using these tools to really help us to bring together multiple lines of data to help a problem that is really challenging from our healthcare system, also challenging for patients to very good effect. So my plea is, we have to be, those of us who care about equity, who understand what the data risks are, also have to think actively about what the potential is here. So what does that mean? We have work to do. So more must be done. We all have to do more. And I go back here to the 5 take-home messages from the committee that I chaired, because they still actually resonate quite a bit for what I think has to be done in here. So first of all, this is an urgent issue. As I said, we've had 3 decades of not including everyone in the studies that we're engaged in. We spend billions in the US on research, but that research does not reflect the diversity of the US, and that's really important. It's pervasive, persistent, and it's costly. And so the need here for all of us in this room, outside of this room, to think about this question is urgent. This requires investment, whether we like it or not, and I know the dean doesn't like that, but I'm going to say it, it does require investment. This requires investment in thinking about how our workforce looks, how our data infrastructure looks, how we make sure that all of the clinical sites that we have in our communities are involved in the studies that we're producing. This type of work cannot be episodic, cannot be transactional. It has to have a persistent commitment in order to get this done well. This requires transparency and accountability. So I don't want to dismiss the issues of trust and mistrust and competing priorities that were brought up by the last panel. Those things are very real. And as are the issues of misuse of data, of using data to harm communities. And so I don't want to dismiss that. And that's why this requires a degree of transparency and a degree of accountability at all points in the research life cycle in order for this to be done well. It is the responsibility of everyone involved. And one of the things that I think was most striking for us in the committee is how often people were very clear that they believed it was really important to have equitable representation in clinical studies, in our data sets. It's really important, but everyone will cite one reason why. It's the IRB that prevents us from doing this. It's the, we don't have enough money from the granting agencies. It's the types of investigators who don't have experience with working with those communities, which are all true. They're all true. So everybody has, it's the way our ecosystem works, is that everybody has responsibility, but no one is ultimately responsible for this issue. And I think that's where those of us who think a lot about this issue do have a responsibility, not just in what we do, but how we also hold our other institutions accountable in the larger research ecosystem. And then finally, creating a more equitable future entails a paradigm shift. So this is hard work, but the very process of doing this work, in fact, creates environments for more discussion that slowly start to shift the balance of power and to put communities and their voices at the center. And I think the issues of data and access to data and people being more empowered to talk about how their data is contributing to the types of discoveries that are being made are starting slowly to do that. And I think our job as researchers, as those who are interested in health equity, is to continue to push this forward. So there's more work for us to do, but I know I'm really heartened by events like this that are putting the issues of data and the issues of equity front and center. And I'm really happy to have more of a discussion about this today. Thank you. I know.
Thank you so much, Dr. Bibbins-Domingo, for that wonderful presentation and for being here with us today. So I think, sorry, my name is Susie Welty. I'm the co-director of the Data Innovation and Technology Hub at the Institute for Global Health Sciences at UCSF. And it's wonderful to be with you here today. So Dr. Bibbins-Domingo was talking a lot about sort of the underlying data, and we've talked a lot about that, but I think we also need to consider sort of the workforce, which she brought up at the end, the workforce that's both doing the coding and building the algorithms, as well as the workforce that's interpreting the data and how that matters. So I'm going to invite my panelists, Dr. Kelly Taylor, Dr. Daudi Jjingo, and Grace Kebirungi to come up. I'm going to introduce Dr. Taylor first, and then she's going to do a quick presentation and followed by Grace and Dr. Daudi. Dr. Taylor is an assistant professor of medicine in the Division of Prevention Sciences and director of the domestic portfolio of the Center for Pandemic Preparedness and Response at the Institute for Global Health Sciences. Dr. Taylor focuses on training leaders in health equity science and building transformative public health solutions with community partners to advance equity and save lives by centering the perspectives of individuals and communities who are experiencing risks for poor health outcomes. So I'd like to introduce Dr. Taylor.
Thank you, Susie, and good afternoon. Are we not quite? Good morning. Okay. So I'm going to start, as Susie mentioned, talking about workforce development. And hopefully my slides will be up in a second. So as we know, the workforce that we're relying on to do both the coding and the interpretation are quite critical, but also the workforce that's going to be implementing this, engaging with community as well, are also critically important. And so a little bit about, I'm going to spend a little bit of time with you talking about what core competencies should we be thinking about for folks who are doing this work. Because as we know, health equity has become such a hot topic, right? It's not new. Health equity, everyone is sort of, using it in their bios. It's a part of the DNA of who we are. It's what we all strive to do and achieve is health equity in our work. But what does that really mean? And what are the scientific kind of underpinnings of what health equity science looks like? And how does that work with us developing our workforce and what we expect them to know around health equity and using it in this space around AI as well as other spaces with regard to eliminating disparities? So my work in general kind of spans a lot of different spaces in workforce development. So I have a program on pathways to careers in public health for people from diverse backgrounds. I do several studies around virtual reality or immersive reality. We're looking at disparities for Black women and birthing people, HIV and stigma, and patient-provider engagement. And then some new work around natural language processing, excuse me, identifying bias in clinical notes. And so that's more the generative AI space. But what I'm going to talk about today is health equity science and core competencies. So I think many of us, again, know what health equity is about and what we're trying to achieve. But I think fewer people know that there are actually definitions out there about what health equity science is. And health equity science is really looking at examining patterns and factors that contributed to inequities. And this is a CDC definition. The NIH has gone on to say that research designed explicitly to promote fairness, opportunity, quality, and social justice and access and interventions and treatments is also critically important to outcomes around health equity and science. So although research in health equity has grown exponentially, highlighting the significant disparities in outcomes, this body of knowledge has not been followed by a standardization of competencies around that. And for many of us, whether we're in public health or social work or medicine, we do have some standards around core competencies or what is expected of us in our fields to have basic knowledge to do the work that we do. So essentially, health equity science applies and core competencies applies health equity research in design. It can explain bias in data, including data collection, analysis, interpretation, and implications. These are some of the things that I'm explaining that we would like to see for folks who are doing health equity science in the space of AI or any other space to be able to articulate in their work. Can they demonstrate factual and conceptual knowledge of historical context when designing and interpreting their studies? And I think this is really a key critical factor because conceptual and historical context really matter for many communities who have experienced health inequities and health disparities. Can folks recognize systemic and structural barriers? Can they co-create research opportunities? And what we mean by co-creating research opportunities, we've heard our panelists today talk about working with community, but really what we're trying to push people toward is that co-creation where you actually start from the beginning and design your research with community or backward design your research with community. So it's not enough to be able to bring community to the table after you kind of conceptualized your idea and you want to move it forward and you want the community's feedback. You really need to have that community input from the beginning. But as our panelists earlier also noted is that many communities don't understand AI or they don't feel comfortable contributing to the conversation. So part of that co-creation of research and co-creation of and collaboration means that it's our responsibility to be in communities, helping them understand what we mean by, artificial intelligence or augmented reality, if that's what your generative AI. And I know that they were saying there's a paucity of that happening out there, but I do want to highlight one group at UCSF, the Health Equity Action Network, which is an NIMHD funded study. And it's a collaboration with folks in EpiBiostat and the Division of Prevention Sciences and others who have convened a Stop Bias in AI group. And it's focused on bringing community into the conversation and level setting community, helping them understand what generative AI is, what the implications are, showing them and interpreting the literature with them, going on NIH Share and showing them what's possible in terms of data sets and what kind of information is going to be out there, because those are the ambassadors we need for community. Those are the people who are going to go in community and say, I think this is a trusted approach, or we still have some questions, but I think it's valid for us to be a part of this conversation. It's essential for us to be a part of this conversation. But the only way we're going to accomplish that is if community really understands and whatever community, the communities that you work with, the communities that you rely on to enroll in your studies, it's only going to happen if they actually understand what you're bringing to the table and what this all means. Otherwise, you'll see similar outcomes, as was noted by others, around what happened with COVID and medical mistrust and other mistrusts around other things that we've tried to institute in communities where there was pushback. We have the opportunity now to really work with communities at the beginning of our process to help them understand what we're trying to accomplish with them and to benefit them. Is it collaborative? Or do they collaborate on community-driven research? Right. So again, our community members are part of the research team in a meaningful way. And again, that also requires some education, because even some of our panelists earlier who are quite well educated also don't know some of the language and some of the terminology, and that's going to be critical in us moving that forward. And then, do they demonstrate cultural humility in working with communities? And so what that means is, it's moving beyond cultural competence and having some self-reflection about, who you are and who you show up as in community. What is your accountability? Who do you represent? We are all out there to do good, meaningful work, but we represent institutions that communities may not trust. So I may show up thinking I am a part of a specific community. I'm a Black woman researcher and I'm very much connected to my community, but I'm also a UCSF researcher. And so when I come into community, that may be the face that they see before they actually identify with me, or in conjunction with identifying with me as a member of the community as well. Because we all know that just because you're representative of a community does not mean that you can't represent harm to community members. So this was a part of an effort, just to kind of give you some context, that from community and researchers to start thinking about what are some of these core competencies that we may need. And this is just the beginning. So this is sort of a Delphi method to come up with what should be some of the core competencies around both health equity research, health equity science, and using AI in terms of what we want our investigators, researchers, and academic communities to know. Thank you.
Thank you, Dr. Taylor. Grace Kebirungi, this is visiting us from Uganda, and this is her first time in the United States. So welcome to San Francisco. She's a project coordinator at the African Center of Excellence in Bioinformatics and Data Intensive Sciences in Kampala, Uganda. She focuses on projects at the interface of technology and health. She also serves as a principal investigator for the Rockefeller-funded virtual reality study that aims to assess the causes of slow adoption of virtual reality in medical education in Kampala, Uganda. Welcome, Grace. Oh. Grace is going to talk about one of our initiatives in Uganda that's working on building the workforce for bioinformatics. But as a partner to that, I just wanted to mention that we're also working with the University of Nairobi in Kenya under this same mechanism to develop a pathway program for data science for young women in Kenya. So she's going to tell you about the Uganda piece, but I just wanted to also mention the Kenya work as well.
Hi, everyone. I'm really excited to be here because it's my first time to be in the US. And so as Susie mentioned, the UCSF Institute for Global Health Sciences, in collaboration with the Infectious Diseases Institute, are working together on a project called She Data Science. And as the name suggests, the project is aimed at advancing women in data science through graduate training And we shall be doing this training at different levels. That is at the internship level, the master's level, the PhD level, and at the level of practitioners at public health institutes. I would like to zoom in a little bit on the level of public health institutes. You all know that at these at public health institutes, that is the laboratories, the hospitals. These are people who generate data for us, the data that we finally get to use in these AI platforms and systems that we develop. So we really find it important to train them in data science for them to be able to understand the importance of the quality of data that they give us. Most of the times we find that data that comes from these institutes sometimes is incomplete. Sometimes people feel lazy to just fill in a little bit of information, mainly because it's paper-based, but we want to encourage them and train them and tell them the implications of them not giving us quality data, or for the data having some missing data. We also want to be able to identify the different impediments of women's progress in data science. Now, it's not just only about training women in data science. We want to be able to understand what are the different challenges they face, what would stop them from wanting to take on data science, or even for those that are who have already taken on data science. Why are there any challenges in them being recruited as data scientists in the different organizations that they work at, or are they being discriminated against? Are they being listened to? So those are some of the things that we want to achieve with this project. And the project aims at training a total of 26 women in data science over the course of 3 years. And this will be 6 internships, have 6 masters, 2 PhDs, and 12 public health practitioners from the public health institutes. So, but why is this really important? Why do we want to train women in data science? Already women are underrepresented in STEM, but also there have been different campaigns in AI towards having more women being represented on the different teams of AI. But already there are few of those women who actually understand data science. So do we just want to add women in those teams just for the sake of adding women to show that women are being represented, or we want to add women who are actually trained and competent in data science? So we hope that with this training, we won't just be adding women to tick a box to say that, oh, we have women representatives, but we want to add women who are actually competent and who will be able to add meaningful contributions to these different teams that they are part of. So we also hope that once we train these women, we shall have a diversity in the data teams to reduce the bias. So women do have different perspectives, and we hope that they'll be able to identify and mitigate different bias that exist. I'll give you an example. Imagine if we want to develop an application for predicting menstrual cycles, or enabling women to know when they're ovulating and when they're not ovulating. Imagine if that platform is being developed by men. How many of the men actually know women's cycles? How many men actually know that women's cycles span from 28 days to 35 days? Even amongst us women, there are people who do not know that there are women who have 35-day cycles, there are women who have 21-day cycles. So we believe that if we are able to have these women on these teams that develop AI solutions, they'll be able to give different perspectives and have meaningful contributions. So we also hope that once these women are trained, it's a quicker way of having community progress, because women are the ones that are always in the community. They're the ones who are always, like, let's say, at churches, in schools, they're almost everywhere. So they're able to understand people's needs at a much deeper level because they have more interactions. Not to say that men do not have, but women are more people person. Okay, not people person, but they engage more with people. They find out, they query more about people's needs. For example, if you ask a man, how are you? He may tell you, I'm fine. But a woman will tell you, oh, I'm fine. But you know, my kid, this and that. Like, they give you a little bit more detail, and so they're able to understand people's needs more. And we hope that once once they're able to be trained in this area, the solutions will be much more inclusive. So so what do we see this project bring? So we see this project being able to address the gender disparity. Already in my country, even within my institution, there are very few women who are involved in science, and we hope that even if there are about 26 people that we shall be training, we hope that at least it will be able to raise that number and have more representation. And as I'd already mentioned, is that women are, they engage more with people, they understand people's needs better. So we hope that we shall have more innovations coming from women and them being able to contribute to different innovations. And of course, it gives them different opportunities, employment opportunities. We won't just have women at just banks or hairdressers, but we shall also have women that are data scientists, and then also be able to challenge the different stereotypes that we have, that people have about women. I'll give you an example. In my country, there's something that we call boda boda, and these are motorcycles that we use for public transportation, but they're mainly ridden by men. And to find a woman riding a motorcycle will be, oh wow, like everyone will be so shocked. Yet this same habit is maybe seen in India, where women, they're able to ride motorcycles, but it won't be something very surprising. So that just speaks to how abilities are not just about, they're not gender-based, but it's just the exposure that people have. And we hope that as we expose more women to data science, they'll be interested to do more data science related work. So thank you so much.
Thank you, Grace. Daudi Jjingo is a bioinformatician and data scientist with a PhD in bioinformatics from the Georgia Institute of Technology. He completed his undergraduate degree in biochemistry at Makerere University in Uganda, where both of them are currently. He serves as the director of the African Center of Excellence in Bioinformatics and Data Intensive Sciences within Makerere University's Infectious Diseases Institute. He was a principal investigator of an NIH training grant that established a master's and PhD degree programs in bioinformatics and health data science at the university, and currently the PI of HEAL, a Gates Grand Challenge project to implement data science and artificial intelligence in health communications for village health teams in Uganda. Welcome, Dr. Jjingo.
All right. Good morning, everybody. I'm glad to be here with you today. And also to note that at least here, there's a considerable majority of women in the room, which, like Grace just said, we're not terribly used to seeing, especially in science fields. So this is sort of aspirational thing for us. And so, you know, I was asked to talk about this, but I'm more excited to discuss it. So I'm looking forward to the panel. I'll just mention a few things about the opportunities, the challenges, and I think the solution spaces that that we are seeing on this landscape. I think a lot of them have been mentioned, but they are, you know, they're really potential game changers in terms of how far these tools can go. And I think Dr. Domingo completed her talk by highlighting some of the potential for this. And for example, one of the work, some of the work we're doing now is related to health communication, which, at least in our ecosystem, we see that health communication is almost as important as the medicines and the drugs themselves. what information patients and the public are able to receive, one, and then two, to process and to understand and to interpret. That's a big part of being healed, believe it or not. And we can explain later. But and then so these tools represent a new frontier for communication, right? You don't have to necessarily meet the doctor all the time. And if you meet them, sometimes I think one of the things that was addressed by the first panel was the stigmatization that surrounds clinical interactions. So sometimes if I'm able to get information without showing my face, especially in places like where we come from, where there are some regulations or laws around, you know, I was seated to Michelle and she was explaining to me things about gender and the 5 types of gender. So some of those things in some contexts, you're not able to necessarily freely show face. And these tools can help you maybe have some interaction without necessarily getting too exposed. Anyway, I think that the issue of helping with diagnosis has been addressed, but then we're also seeing use cases in pandemic preparedness. So we come from a part of the world where pandemics are fairly common, especially where in Uganda for so many reasons, but most of it being right on the tropics. And so just the ability to detect these things before they become a real issue becomes super important. And I think these tools, again, provide a new opportunity to be able to see some of the signals, perhaps before what classical methods would have seen. Obviously, language is a big thing. Most of the tools, I think it's been explained before, most of the tools are developed in English. And so these tools can help a lot with translation, and that is a big part of clinical interaction. I think here you have English speakers, and I think it was Solange who mentioned non-native speakers. We have the same issue, but for different languages. You know, we have maybe about 40 languages in the country, but maybe 8 or 9 of those are the most common. But even with these 8 or 9, you have a doctor speaking that language, a patient speaking that language, and sometimes the mother speaking another language. So facility with language translation becomes super important in environments like that. So those are great opportunities these things can give us. But obviously, they come with a bag of issues, and I think several have been well explained before. I'll just mention some which have probably not been so addressed before. For example, there's the text-to-speech, bridging the text-to-speech issue, which we're seeing very well, and it's related to language translation, but also communication. Because, you know, what you're able to understand from text sometimes is a bit different from what you would understand if you had the audio from somebody. You know, if they have a heavy tone, or they are annoyed, or if they, you know, they show certain facial, what do you call them? Facial expressions. Yes, thank you. If they show certain facial expressions. And so a lot of these tools are text-based, as we all know, ChatGPT and all that. But I think one of the things that we are actively trying to work on is to try, how do we minimize this gap between text and audio and actual interaction, so that there's minimal value that is lost in translation between those spaces. I think that's a major issue for these tools. In our specific setting, we do have infrastructure issues. So over the last few months, we've been working on, we got some GETS funding to work on what we call HEAL, which is an application that Grace referenced, which tries to help frontline health workers interact with fairly inflexible text. But you know, some of the issues we quickly ran into were infrastructure issues. where do you train the models? We had GPU issues, and that took us a lot of time until, somebody at the University of Georgia, I studied in Georgia, which, it's not California, but so yeah, helped us get some GPU stuff. By the way, those are some of the differences, even in the US, right? Communication, I hope I don't mess up a bit, having studied in Georgia. But infrastructure is a real issue, and it's also an issue of equity, because if you want to people to involve in the entire pipeline of these tools, not just as users, but also as developers, because that's where it all starts, then they also need to be empowered in terms of the infrastructure that is required to enable this sort of thing. Of course, there's the issue of under-resourced languages. I think ethics training is also the ethical terrain that surrounds these tools is, of course, something that is very much in development. And then it gets mingled with the legal issues. Of course, there's different legal regimens in different parts of the world. And, there can be quite a bit of a mess, and standardization can be an issue. So there are several challenges, and several have been mentioned. And there's some solutions. There are some standard guidelines that we've been working on with the WHO for under-resourced countries, how these tools can be used. And also some solutions. Actually, yesterday we had an engagement with a group here in NLP, and they pointed us to some solutions for this difficulty here, which turns out is actually the standard technical solutions that we could follow to solve that, because that becomes an issue for most of these tools. You need to be able to demonstrate the value, and that's not always easy to do that in communities. So, of course, within our country, and you can all tell I'm speaking with a quote-unquote an accent, and that can be an issue, of course, both between English and other languages, but also even within our countries, which are extremely multilingual, accent becomes an issue. So if you had me from Central Uganda speaking English, and you had somebody from Western Uganda speaking English, you might think we are talking different languages because there's the accent issues. So even, but then training these tools to be able to help with that seamless translation beyond language, but also including accent, I think is a great potential. Prompt engineering, that is just specifying where they should look and how they should look in terms of that. Transfer learning is one of the tools we're using for translation. I think we could explain that later. We're beginning to grow data sets. So I think one of the things that especially AI could do for us is growing resources, language resources for unresourced languages. And in my view, most languages except English are fairly under-resourced. But to the extent that AI could help us even generate and simulate content in those languages, which can then be used to train models and that sort of thing, I think is really, really a great opportunity to empowering these sorts of language spaces. Of course, as always, local contextualization is a key thing, which is beginning to happen, but will be exciting, I think, when we start talking about it in the discussion. Thank you so much. Again, I'm happy to be here and I've already learned so much listening to these talks this morning. Thank you.
So moving right to a panel discussion. That's okay. So I hope everyone has their mic. So really great, very interesting presentations. One of the things that that really comes through, certainly in the first two talks, is the workforce that we need, both a workforce that has specific sets of skills, as well as a workforce that thinks differently about the problems, and that might work together on a team that has multiple disciplines on it.
how do you talked a little bit about this, Kelly? How do we, who are the people we're trying to train, and what specific ways? Are we doing this from scratch as people come up early in their training? What about all of us who are sitting here who are interested? What are the ways in which we help build those skills?
So in terms of like building teams, I think there are definitely models out there. There's a whole science around team building, the science of building teams, team science. And so that's bringing together folks from different disciplines and backgrounds to solve a common issue or address a problem or come up with a research question or move something forward that needs to be addressed. And I think using that same type of model in terms of identifying what skills do you need at the table, and thinking a little bit broader, because I think oftentimes when we, even in the team science approaches, we think of the traditional skill set. So people have mentioned today bioethicists, we have data modelers, we have statisticians, epidemiologists, social scientists, a broad expanse of folks. But again, often missing that piece from the community engagement or the community's involvement in teams, and not just creating the team for the sake of team, but making sure that the complements of the team work toward the common goal and that everyone feels like they have an equal contribution. Because I think once we add community members who are not necessarily trained formally as we are, but have that lens that we need to be able to execute whatever it is that we need to execute with regard to AR, and build it in a way that represents the diversity of voices, experiences, and needs, then I think that the power imbalances often shift in those teams and their voices are still not really heard. So I think just being very deliberate and having a roadmap for how to build that team, and not just sort of willy-nilly, for lack of a better term, putting the team together.
So it sounds like we're gonna, even though there are things out there about how to work on multidisciplinary teams, we're probably gonna have to have we're gonna have to pay particular attention to the skill sets here, particularly as they involve community members and the power dynamics and those types of things.
Absolutely.
Grace, what do you see in your setting in terms of we're training women to be informaticists and to join these teams? How do we, what are you seeing in your setting that is the challenge or could be enhanced for building teams that have all of these different experiences?
Yeah, thank you so much. I think one of the most important things, as Kelly said, is being able to have people both contribute to a problem. But what I find so important is if for example, we have a computer scientist on the team, would need them, for me who is not a computer scientist, we need them to break down things for me, to explain to me so that I'm also able to learn. Right now, if I speak about NLP or AI, you could sort of mistake me for a computer scientist, but it's not because I'm not, it's not because I went to school for that, it's because the team that I'm with always tries to break down things for me, explains to me the why, the what, and the how. So I feel like that is one of the ways we can overcome the challenges of having different teams or different people with different expertise on the same team, them being able to break down things for the rest of the team and them being able to learn from each other.
So that really means that training is training those who are experts in ML, computer science, to also have those skills to enhance their ability to communicate within the context of that team as well.
Exactly.
Wonderful. Daudi, you talked about how these tools really are going to help with communication, that is one of the big opportunities. And that really resonates for me. I think a lot about that now in terms of how our journal tries to communicate, is that there's so many opportunities. What do you see where do you see the opportunities? Do you see this in all facets of life? Do you think it can help us to actually also build our teams in a way to do this better? How do you think about the opportunities?
Yeah, and thank you for that. So multiple things. So so first of all, these tools, I think one of the things that came out earlier in the discussion was the idea that the data that goes into these tools has to be balanced in several ways to minimize bias. I think that is very clear. But in terms of communication, what we're beginning to see, at least in our ecosystem, is that even on the other side of that pipeline, so the interpretation and understanding of the outputs, even when the input data and there is no bias in the sampling and all that, what they put out often also needs interpretation for so many different reasons, including the fact that often it's, there's a level of technical jargon that surrounds what they're putting out. There's a level of it's easy to misconceive, especially in communities where what do you call it in English? Literacy, where literacy is not a guarantee, and or where it exists, it's sometimes suboptimal. People are literate, but to a certain extent. So we have a job to do even beyond ensuring balance in terms of the inputs, but also on the output side. How do you explain these things? How do you make them friendly, and how do people appreciate them? So I think that is one great opportunity. But even in that interpretive space, if I'm to call it that, I think these tools can still be useful. I think one of the other things that where I think we have an opportunity is, so, and again, this is about bias. So one of the issues that was raised was to try and diversify either the teams that are working on this data, but also the data that is being collected, so that is more representative, which is absolutely right. But again, with some of the work that we're doing, we're beginning to see that diversity, at least in this context, and I hope I'm not saying anything messy, that diversity, at least in this context, sometimes is not necessarily always a panacea, and I have to explain that. So sometimes, especially where you have very heterogeneous communities, so you want to have, diverse inputs of the data so that the model can be more generalizable. But then sometimes we are seeing that maybe sometimes if a model is going to be targeted at a certain community, then maybe you have to be careful about making it more generalizable. Maybe you want to train it just for that community and just collect data in that community so that it can have more relevance in that community. Now, of course, in statistics, we talk about overfitting and that sort of thing, which is not necessarily always a good thing. So, but I think there are opportunities to consider what is appropriate when. And that the panacea sometimes might need, is it panacea? Is that the English word? That sometimes might need moderation. So I think there are opportunities there of use cases which could be helpful in terms of how we use these tools thoughtfully and distinguish in different use cases where they're being used.
Thank you very much. I'm curious whether you've all been working in these areas for a while, and AI is one of those things that has really accelerated both the potential as well as the concerns. I'm wondering whether you are what you would say would be I'm curious whether you're optimistic about the future, and if you could say one thing that you could leave us with and would give you hope for thinking about how to work more closely with communities here in the U.S. in other contexts. What would that be? Kelly, maybe you can start.
Yes, I'm definitely optimistic. I think this, as many of our speakers and you as well, Dr. Bibbins-Domingo said, it has great capability and it's an amazing opportunity. I think for communities in which I work and belong, it does, I feel like, have the capacity to narrow those disparities, gaps the ones that, I mean, the health disparities that we've been addressing for decades that are not changing and some actually worsening. And so I think there's a lot of optimism around this tool in particular, or generative AI and machine learning and large language models can, what it can help accomplish in terms of addressing those from multiple different aspects. And so for my own, like in terms of looking at clinical notes and helping providers better understand how they're communicating with their patient may not match what the patient is experiencing in that encounter, or it may represent some biases that in their own thinking that they're not recognizing, that they can help them kind of rethink and retool how they do their work. So for me, I think it has a great possibility of being able to be extremely helpful in that area. And I look forward to seeing what my colleagues and hopefully myself will be able to accomplish in that space.
What thing would you like to tell us that how can we make sure that the attention to equity, the attention to community in a empowered way involved in speaking to the priorities, or what would be the thing that you think is the most important thing we should focus on to make sure that that doesn't get lost?
I think inclusivity is probably the most important thing. I think the broad, I think in some contexts, as Daudi said, that may not be applicable, but I think in the context in which I work in the United States, I think as broadly inclusive as we can be to teach these models is what I would hope for in equity. And I think that's going to be the only way, or one of the key ways that we can help achieve that using this particular tool.
Wonderful. Grace, you've given us so much on International Women's Day. It's wonderful to hear about the program training women in particular. What is the thing that makes you optimistic, and what's the thing that we have to pay attention to make sure we don't lose sight of the equity issues in this from your context? So so certainly a program like your training program makes me optimistic about the future. What are the things you think such programs need to make sure that we don't lose the focus, to make sure that we have women and others involved in the workforce for AI and machine learning?
Yeah, for me, I think that even with the training, we need to look at other factors that affect or impede women in going for these training sessions, either in data science or whatever, because as I'd mentioned, that women do have different roles, and specifically in my country, women are the ones that do take care of the home and all those kind of things. So can we be able to create an enabling environment for women to be able to come and attend these classes or these trainings that we do have? So if we are able to put those measures that encourage them to be able to attend the classes, then that increases the uptake or the acceptability of our training classes.
Wonderful, wonderful. And Daudi, you have such a great sense of so many aspects of both the potential for this technology in your setting. What is the biggest barrier to getting from here to there for us to being able to realize that potential?
Right. So, there's several barriers, but I think you say what's the biggest. I'm going to give you three. I'm going to cheat. And that's because maybe they're all important. So one of the things is something that we referenced earlier on, which is literacy. And I mentioned that earlier, and I know that in the US it's not really an issue. Maybe it is, but not as big an issue, because all these tools, almost by definition, are not natural mediums of interaction. It's not like I'm just going to talk to my mom and have a conversation. We either need a phone, we need to be able to read and read well. We need and sometimes even the information needs context. So if I've lived in the US and somebody mentions something about something in the US, I might be able to contextualize it. But this applies even in our communities. So I think literacy and good literacy and just education and having people, get those opportunities, I think is great. Is a number one requirement for these. So I think that is one thing. The other thing that I see on the good side is that you could see it as an impediment because, again, in our communities, there are things that are not yet as acceptable as they are here. And so I think, so the problem there would be that those individuals might not have the flexibility, the expressive ability to express what their issues are. But I think these technologies provide that opportunity. So it's a problem in the sense that it makes somebody anonymous, and these tools that's a great risk for these tools, the anonymity that they create. But then also sometimes that anonymity can be useful, especially where we call them key populations. Key populations, I think around gender, around sexuality. So they make those people faceless, which is a risk, but then it's also an opportunity because sometimes that facelessness is value to those individuals. So I think that is one other thing. Then the final one in terms of the roadblocks that this could have is again just infrastructure. I mentioned literacy, but then infrastructure in terms of gadgets, in terms of internet, in terms of connectivity, because almost all these tools one of the things we're working on right now is a Hill product, which we're building using LLMs. But these LLMs are usually big models, and it's hard to run them on without a connection to the internet. And we're trying to think how could we condense them so that they could fit on gadgets that are not connected to the internet. And I have a fancy, by our standards, a fancy Google Pixel phone, which does a lot of things, but the average person will not have a smartphone, right? And so how do we make these tools accessible? So I think infrastructure is sort of like another impediment.
Wonderful, wonderful. Thank you. I think, are we okay? I don't know if we're on schedule or not. We're late. It's been such a pleasure hearing all of you talk about the issues about workforce, capacity building, engaging community, and both the power and the challenges that we have in this environment. So really a pleasure to spend some time with all of you. Wonderful. Thank you.
Yeah. Well, with like anyone for maybe the whole first half, I think. We haven't had that opportunity yet. Gosh, I feel shorter than ever. So thank you to our panelists. We are going to take some audience questions now, if there are any. Anything you just heard or anything from the whole morning so far? Just if you raise your hand, we'll bring a mic to you. No. Thank you. Thanks, Mandy.
Hello, my name is Sara Ismail. I'm here with a few of my colleagues from the Center for Child and Community Health. We're at the Department of Pediatrics. And I had a question for actually the audience, because I heard that there's some trouble gaining access to patients and patient advisors in the community. I wanted to know, where are your go-to resources? Because we are a resource in the Department of Pediatrics. We actually advertise that we have a young adult advisory group that is trained on research principles, and they can review your research, and it doesn't have to be in the Department of Pediatrics. And we have 4 other community advisory groups. So we're happy to be a resource, but I'm just wondering from everyone here, where is your go-to resource?
So my name is Jan Yeager. I'm a service designer with the Clinical Innovation Center, and I'm a human-centered designer. And designers naturally co-create with their users. You know, that's just what we do. So patients are part any matter provider, nurse. And so the intent is to get access. It's very difficult to do. I often rely on providers who will identify some patients. Sometimes I do cold calling. So I do think I have used advisory groups a lot around food service design, but I think the platform to have access to patients is missing here. So, it is more. That's great.
Hi, I'm Leslie Yuan. I work at the Clinical and Translational Science Institute at UCSF, and there is a community engagement program within the CTSI that will give free consultations for people doing research. So that's a easy form to fill out, consult.ucsf.edu, and hopefully that's a resource that everybody can take advantage of as well.
Yeah, we used CTSI when we were recruiting and designing.
Any other questions? No? Okay, well, thank you. Please, Victor, sure, of course. Madeline will bring you a mic.
So sorry, this question isn't for any of the speakers and panelists, although they were great presentations. I wanted to ask you about your role. How common is that role throughout this? You're the only one. Okay. Are there plans to expand or hire more? Okay. Thank you.
I can't wait for your talk. I do know that.
Well, I love it. We have connections already. I mean, we're here to be building community. So, okay, well, if there are any more questions, so lunch is running a little late, but it will be here. So if you are hungry for lunch, if you venture out, definitely come back to grab a box or a bowl. If you leave, I was going to suggest maybe taking your things with you, maybe really valuable things with you, because I think we'll all be kind of milling about for a little bit. And then we hope you'll join us this afternoon for the design portion of our day. Thanks.
Beth?
Hello, welcome back. Now you guys can hear me. My name is Beth Berrean, and I've been a designer with Somtech for a really long time. Right now, I'm working in the Office of the Chief Research Informatics Officer, Ida Sim. And as you can imagine, a lot of my work in the CRIO's office involves much of what we've been talking about today. AI, AI, AI. What the AI has been trained, the data that AI has been trained on, what our responsibility is around the use of AI, and how we really sort of deal with it. And so I'm so excited to be taking all of those questions and those insights that we heard this morning and translating them into the second half of our day, where we're going to talk about something that I think has one possibility to explore all of those questions, which is design. You know, when we talk about AI, when we talk about technology, all of those things are embedded in sort of a societal, communal, organizational constructs. And design really gives you, especially radical participatory design, gives you one tool to really explore those constructs and to play with those constructs. In my career here at UCSF, I've been lucky enough to work with a couple of researchers, a couple of PIs who have been very committed to community-based participatory research. And we've worked on projects and tools to build, to co-create and to co-build tools that get at health equity to reduce health disparities. But a couple of projects isn't enough. I want to do more of those projects. I want us to do more of those projects. And so I'm really, really happy to have Victor come speak to us today, who not only gets what we're trying to do, but also gives us new tools to explore. And so when Jonathan first heard Victor speak a couple of years ago at a commercial conference, he was so excited. He came back like a buzz, on fire with like what Victor was saying. And so I'm really delighted to make Jonathan's dream come true and have Victor talk with us today. So Victor Udoewa is a service design lead at the Office of Public Health, Data Surveillance and Technology at the Centers for Disease Control and Prevention. He was previously the Chief Technology Officer, Chief Experience Officer, and Service Design Lead for NASA Small Business Innovation Research and Small Business Technology Transfer Programs. He was Director of Strategy at 18F, a civics consultancy for the federal government embedded within the federal government, where he led digital strategy practice and served as a designer and strategy on projects. Previously, he worked as a global educational instructional designer and training development specialist at Google, where he designed learning products and services for people in low to middle income countries. The educational could range from experiences covering how to develop web applications and how to use the internet to improve teaching and learning, to experiences exploring how to use technologies in post-disaster emergency response situations, as well as global digital literacy. As part of that work, he also advised Google on global energy and access work. Prior to Google, he served with USAID and DHS as a science and technology policy advisor and development engineer focusing on infrastructure, post-disaster recovery, post-disaster reconstruction, climate neutrality, global health. He sometimes serves as an adjunct professor of design, education, and computer science and math, and he still conducts and publishes research in engineering, design, and education. He's a certified health crisis and trauma counselor for HIV, AIDS, and miscarriage, et cetera. And he also enjoys singing in his choir and teaching salsa classes and enjoying time with his family. So please join me in welcoming Victor to UCSF.
Wow, that's an impressive bio. I don't know if it's all accurate, but yeah, it's good to be here. Just waiting for the slides to come up. And I'm not going to give any health examples, even though I'm at the CDC, but hopefully you can see the applicability to that as we talk about it. You people always come here and you take and you take and you take, and I never see a single thing change. Go, just go. These were the words that greeted me upon entering a community in North Central India and trying to begin a conversation with the gentleman who was squatting on the ground. You see, when he looked at me, he saw a legacy of researchers, of experts, sociologists, anthropologists, designers, and researchers who used extractive, transactional processes to get the things they need, but with no benefit to the people. You see, if we're going to ever engage in community-led, community-driven research, we have a legacy to contend with, and there are some changes that we have to make. So thank you for coming. My name is Victor. We'll be talking about radical participatory design and research. I bring you greetings from Washington, D.C., the East Coast. It is the land of the Nacotchunk and the Piscataway. The Nacotchunk are a people group who, because of persecution, fled to a tiny little island in the Potomac River called Theodore Roosevelt Island, and because of further persecution, moved into Maryland, just outside of DC, with the Piscataway, and together with the Piscataway, due to further persecution, moved up to Pennsylvania. You see, these people groups were people groups before the colonists arrived, when the colonists arrived, and still today, and I honor and acknowledge them and this land on which I move, breathe, have my being, and do this work. Now, land acknowledgements don't change a single thing about the allocation of power or resources. What they do is work at the level of mythology, and there is a mythology around participatory research. Remember, with the mythology, it doesn't matter if it's true or false in a scientific sense. It only matters if it's alive or dead. And there is a living mythology around participatory research and design. So join me today as we seek to perturb or disturb, unhouse, or unsettle that mythology. Join me as we seek to decolonize the history of participatory research and design. Now, if you ask most people, when did people or Homo sapiens first arrive on this earth? The oldest bones that we found are around 300,000 years old. And then if you say, well, in that whole time, when did participatory design start? They'll normally say something like, well, 1970s with collaborative design in Scandinavia. Sometimes they might say, well, 1961, you have Carl Lin, who was the father of American participatory architecture, and he built the first community build and design center in Philadelphia. The same year that Jane Jacobs published his beautiful book that critiqued the centralized model of urban planning and planted the seeds for a participatory movement in urban planning. Some people might say, well, 1940s in Europe, you had these researchers, these academics who talked about participatory action research. But whether 40s or 60s or 70s, are you telling me that all three arrows on the right are right on top of each other? Because for 300,000 years, there has been no participatory design? Really? Well, what if design is just planning and doing and creating in ways that affect you, your environment, and your world? And if that's true, I'm willing to bet that there actually have been examples of participatory design before the 40s, 60s, or 70s. Actually, come with me as we travel to 13th century West Africa, where communities were trying to deal with the question of how to remember. They came up with an embodied design called the griot. The griot was the community archive, the oral historian, the social memory of the people. And using tools and methods like songs and fables and poems and parables and epic tales and narratives, where it was able to tap into that deep connection between story and the human psyche to both better remember these histories, but also to better embed those histories in the minds and hearts of the people. We could go to ancient Mesopotamia, where people were dealing with how to feed all these people as civilizations were growing because we were doing more farming. If it rained too much, the crops are ruined. If it didn't rain enough, we didn't have crops. So they built these large storage basins, and they dug today what we call canals from the rivers to these storage basins, and they built up the sides of the river. So if it rained too much, they stored the water in the basins. And if it didn't rain enough, they led the water from the basins to the farmlands. We could even go to India, although this is true in many different countries, where they were dealing with the challenge of how to conserve medicinal plant knowledge. They came up with 3 different designs: traditional systems of medicine, in which they encoded traditional medicinal plant knowledge in ancient scriptures and texts; folk medicine, which you learned by doing and you pass it on through oral tradition; and number 3, this is the embodied or the expert approach, in which you put medicinal plant knowledge in a person, a shaman or a spiritual healer, and it was passed through apprenticeships. But even if you go 3,000 years ago, when traditional systems of medicine were coming up, whether the Ayurvedic or the Siddha, it was only codifying folk medicine that had existed for thousands of years before that. So when we look at that timeline again, remember, there is no separate start of communities that is distinguishable from the start of participatory design. As long as there has been communities and people have always been participatorily designing. In fact, we could even go before Homo sapiens. We know that trees can use mycelium to send signals between each other to warn of impending danger. We know that there are trees like oaks that grab roots below the ground to create greater resilience for hurricanes and tornadoes. Birch and mangrove and ash rise up from one root. It exists all around us in the entire ecological system, even before humans. You could ask the same question, well, what about participatory research? Well, again, oldest bones that we found from Homo sapiens are 300,000 years ago. Now, most people will tell you participatory research began maybe in the 1970s with Paulo Freire in this beautiful book, if you haven't read it, Pedagogy of the Oppressed, which started really critical studies in pedagogy, but in a lot of other fields, and Orlando Falls-Borda. Some people might say, well, in the Northern tradition, again, you come back to the 1940s with these European researchers doing participatory action research. But again, both those 1940s and 70s, those two arrows are right on top of each other because for 300,000 years, there has been no participatory research. What if research is just gathering and collecting information, storing information, analyzing information, synthesizing information, transmitting information, communicate? Wait a minute. If that's what research is, there's been lots of research. In fact, join me as we travel back to 14, 15, 16, 17, 18, even 19th century in Africa. Specifically, let's go to West Africa, where you had slave traders who were inciting greater rivalries between people groups, right? So now there was even more incentive to capture prisoners of war, and they would take these prisoners of war, sell them to the slave traders, march them down to the coast, store them in slave castles, and put them in ships across the Atlantic in what we call the Middle Passage. And sometimes in preparation for this, or if you knew a raid was coming, the oral history says that the women sometimes would braid seeds in their hair. There were different kinds of seeds, but often these were rice seeds. And if they traveled across the Atlantic, they sold on the auction block and sent to the plantation. And after a full day of slaving away for the master, they would ask each other in today what we would call participatory asset mapping. What do we have here amongst ourselves to make a life? We've been slaving away, making food for the master, but what do we have here to grow for ourselves? And if their hair hadn't been shaved, they could unbraid their hair and say, well, I have these seeds from our homeland. We could go to ancient Greece where midwives were trying to figure out, how do we find methods for birth control? And they actually ended up talking to animal herders, and the animal herders said, well, we don't know, but actually when these animals eat these particular plants or herbs, they tend to give birth less. And that information was transmitted to those midwives who took it back into their practice. We could even go to before Homo sapiens. 2.6 million years ago, they would take rocks and hit it against something, and it would create those sharpened edges, which you see over there. That eventually led about 1.6 million years ago to hand axes. And then eventually 400 to 200,000 years ago, you had something like these types of cutting blades that well, they're called knapping tools, which are similar to the thing on the right. But eventually around 80 to 40,000 years ago, you get these cutting blades, which you see on the right. And that led around 11 to 17,000 years ago to microblades. And eventually 12,000 years ago, you get chisels and axes. This is research through design, research through experimentation. So again, we go back to this timeline and we say, well, wait a minute, then there has been no separate start of communities that is distinguishable from the start of participatory research. As long as there have been communities, there has always been participatory research. In fact, we know that research even exists before people. Ice caps store information, trees store information about the times that they have lived in as they grow out, and we can study that information. It exists all around us. And I think part of the problem, why we misunderstand what this is because we have different, or maybe more specific or narrow definitions of what knowledge is. Right? When we say knowledge, oftentimes we mean mainstream institutional knowledge, the kind of knowledge you get from a book or a college or a university or academic paper or a degree program or a professor. But there are other kinds of knowledges: energetic, emotional, aesthetic, intuitive, embodied, relational, community, spiritual. And research justice says all of these knowledges are equal. They're equal. But if that's true, if all of these knowledges are equal and there's so many different kinds, then wait a minute, that begins to change or transform the definition of research from an investigation to a pluriverse of definitions. And then that changes the definition or the purpose of research from an investigation to establish a fact or reach a conclusion to a pluriverse of definitions. So what exactly is participatory research? What's participatory design? And in fact, there are many different terms for this that you'll see people use. You know, you might see co-design, collaborative design, and the same thing happens with participatory research. You'll see community-based participatory action research, participatory action research. There's different things. You'll even see citizen science, co-research. Usually people mean generally the same thing by these terms. The first thing people generally mean is when I do research, I interview people. Therefore, they are research participants. Therefore, I am doing participatory research or work. The second definition I've seen is a method, right? Oh, let's do a quantitative regression analysis. No, a concept. Oh, why don't we do participatory research or participatory design? The third definition I've seen is not a method, but a way of doing any method. So we have something sometimes as designers called a design studio. We'll get people together and we start to come up with ideas. We'll make paper prototypes. Oh, wait a minute. What if we invited the community to do it with us? So now I'm still doing a design studio, but I am doing it participatorily. The fourth definition I've seen is a collection of, well, we normally say methodology, which I define as a collection of methods or a set of guiding philosophies or principles that help you to choose a particular method at a particular point in a process. Now, whether you mean interviewing people as research participants, a method, a way of doing a method, or a methodology, and all of these different ways of defining, the researcher, the designer, the expert, the professional is centered, right? Sorry, I didn't show you this. This is an example of a methodology, participatory design toolkit. But in all of these ways, as I was saying, the researcher, the expert is centered. And we use the mode of designer or researcher or expert or professional as facilitator. And in that mode, we empower people. But remember, when we empower people, we actually reinforce the hierarchy we seek to subvert. We choose who participates. We choose when, how, where, why people participate. No, in radical participatory research and design, we say, no, we don't empower people, we let go, and the community will assume power. In fact, think of it like this. If we have a workshop on Monday, and we have a second workshop with the community on Wednesday, what are we doing on Tuesday? We're looking at the outcomes of workshop one and trying to decide what information from workshop one will we carry over to workshop two on Wednesday. We're looking at the outcomes of workshop one and trying to see, is it in line with the goal of the workshop series? We're looking at workshop number one and seeing, did any new information come up that changes the direction and sends workshop two in a new direction? All of this interpretation, decision-making, evaluation is happening without any of the community members present. No matter how much we try to neutralize facilitation, facilitation is power. No, in radical participatory research and design, we use a different model. We use a model of designer or professional or expert or researcher as community member. Well, wait a minute, Victor, what do you mean community member? They're not a community member. What I mean is that this person or us in this room, we sit equal to and alongside all of the other community members, and that the skills that we bring, research or design, sits equal to and alongside all of the skills, talents, abilities, giftings, and crafts of these community members. The second model we use is community member as researcher or community member as designer. This sounds self-explanatory, but you'd be surprised how many methodologies or toolkits don't involve the community members actually doing research and design, even though it's called participatory research or design. And the third model we use is community member as facilitator, because if you change who facilitates, you can change the outcome. There are three characteristics that I've observed when doing these projects. Number one, the community members are always present and they're always leading. There are no meetings, planning, debriefing, any type of interpretation, evaluation apart from them, because they are full-fledged members of the team. They are the team from top to bottom, beginning to end. It's not a back and forth. I involve them, then I go back to the lab or studio, then I involve them. The second thing I've seen is that they outnumber, usually in radical participatory projects, they outnumber the professionals, the experts, the researchers, the designers. And the third thing is that the community members own the data, outcomes, artifacts, as well as the narratives around the data, outcomes, and artifacts. I usually ask three questions: who initiates, who participates, and who designs? So in community design, it's just the community. They initiate, they do the work, it's just them, there's no one else. In community-driven design, regardless of who initiates, the community is always participating, and they might invite some professionals or experts. You know, if we're doing a participatory placemaking project, we might involve a urban planner or civil or structural engineer and say, hey, can you come in and help with this one thing or take a look at this? but they're always leading. Usually when we say participatory research or participatory design, we mean what I call CPR or CPD, colonial participatory research or colonial participatory design, where regardless of who initiates, it is the expert, the researcher, the academic who is kind of in charge. And they might involve and allow community members to participate, but we never ever get to equitable co-leadership. We don't get there. Instead, what I'm inviting you to do today is to enter into what we call radical participatory research or design, or just work in general, in which, regardless whoever initiates, the community members are always participating up to and including equal co-participation, and they are always leading up to and including equitable co-leadership. This then challenges the notion of research justice. Why would I do that? Research justice is good, but research justice says that these things, these different kinds of knowledges are equal. In radical participatory research and design, we say, no, these other knowledges are greater than mainstream institutional knowledge. Well, wait a minute, Victor, you're just being controversial. No, when we do mainstream institutional knowledge, we're usually, to be honest, studying other knowledges that already exist, that are already embodied, that are already in the community. In other words, mainstream institutional knowledge lags behind these other knowledges. It's very difficult to work on issues and solve problems based only on textbook knowledge. There are many things, I mean, not everything, but there are many things that we can solve. I might know that, okay, I feel this way because I haven't slept enough, or maybe I'm dehydrated, or I need to eat. There are some things that we can kind of solve, not everything, but it's very difficult for a doctor, a medical clinician, a nurse, a doctor to actually help you and resolve your issue based on their medical textbook knowledge and no lived experiential knowledge from you about what hurts and when it hurts and why it hurts and where it hurts. It's very difficult. In fact, some of you may remember, I don't know if you've ever seen this show in the United States. Yes, it's a United States show called House. Famous diagnostician. He would receive these patients that they had gone through many hospitals and clinics and doctors who could not figure out what the problem was. And this diagnostician called House, that was his name, he had 3 or 4 resident doctors that worked with him. And for whatever reason, these patients would come to him, and I don't know if it was guilt or shame or whatever it was, they weren't telling the diagnostician all the information about their life. So this diagnostician, I do not recommend this, would send his doctors to break into the home of the patients to get lived experiential knowledge, because it's not enough to have the mainstream institutional knowledge. They needed that to help these patients to figure out what was wrong. Even a woman who's giving birth begins to move their body in certain positions, and there are certain positions that tend to be less painful, and those tend to be the ones that are more conducive for delivery. We have embodied knowledge all day long that we need to learn to tap into more and more. So really, my point here is that these knowledges are so much more important. They lead, they're ahead of the mainstream institutional knowledge. In fact, I want to tell you about some of the benefits of radical participatory design. And before I do that, I want to show you 2 example case studies that I'll use to talk about the benefits. The first is an international digital literacy project, okay? Working for a multinational company, doing it in partnership with multiple governments around the world. And we're going to build this technology and curriculum and program and services, many different things. And there was a part of it that was teaching people how to make web apps and mobile apps. And there was a part of it teaching people how to be trying not to use technical terms, system administrator. But the biggest component of it was a digital literacy component. And that's the part that I'm going to focus on. This is going to be an example of a successful radical participatory design project. But I also want to give you an example of a failure, because I fail, or when working with communities, we fail multiple times to do this well. This is an example, a local example from Washington, D.C., an international summer service learning program for high school students. We take them to a foreign country during the summer to do service learning projects. Then they come back to DC and they do local projects in their community. And this was done for a nonprofit in collaboration with the local city government, the school district. This is an example of a project that failed. And I want to use both of those to talk about the benefits of radical participatory design and research. Number 1, the best way to do truly inclusive work is not trying to do inclusive recruitment and things like that. It's just to have an inclusive team. You see, when you have an inclusive team, the rest takes care of itself. So notice in this example, this digital literacy project, In the last column, I'm off doing what we call a, what do we call it? Contextual immersion. I'm doing a participant observation. I'm doing a homestay. I'm staying with a family and I'm just learning and watching their ways, and they've welcomed me in. But everybody else who's local, divided up into two groups, and they're going to two different communities where, number one, they speak the language. Number two, they have established networks. And three, they have lifelong relationships. They're easily able to reduce anxiety and to have conversations that I cannot have because the team is inclusive. Number two, if you truly want to center the design process or research process on humans, the best way to do that is through radical participatory design, is to have the actual humans there at every phase of the work. In fact, when you do radical participatory research or design, you most likely, every case I've been involved in, move away from human-centered design and its problems, because there are problems with it, towards community-centered or society-centered design, or even life-centered or even planet-centered design. I have an example project. I'm working with a school in DC, and I'm not listing out the information, but I want you to see that I didn't tell them. They began to think about needs of their building, of their plants and the compost. They're thinking beyond a kind of anthropocentric, a human-centered look. They're looking more ecologically. I had one project in 2016 about drinking water. It was a translocal project, so multiple cities. And I want you to look at the design challenge that they created. Safe, sustainable, equitable, affordable. Now, normally with our lens, we say, okay, that sounds good. Nothing special about that. But I want you to look very closely, because when they meant it for animals as well. When they say safe or equitable, they meant it for their ecosystems as well when they say sustainable. So it was broader than just being human-centered. And I don't even know what number I'm on, but number three, empathy is an impossibility. So stop chasing it. This is a controversial thing. You know, people don't like me to say this, but you will even see this in a few papers in the social work literature that say, look, because of the inherent power imbalance between the social worker and the client, empathy is an impossibility. We have the same imbalance with our privilege as the researcher or the designer or the academic. In fact, when we say empathy, we usually mean intellectual, or what's the other word, cognitive empathy, knowing what the community member is going through. Rarely do we mean emotional or affective empathy, feeling what they are feeling. And we almost never mean motivational or compassionate empathy, which means where I'm moved to act because of the feeling that I got, because of the information that I had. Usually, we have the intellectual or the cognitive. The affective is really hard, but the one that's impossible is the motivational or compassionate, because we don't know if we would have been moved to act if it were not our job and we were not being paid to do it. Oh, wait a minute, Victor. We did that nonprofit pro bono project. We weren't being paid. Yes, but we still had an agreement with the organization or the community that we were coming in to do research in order to take action. We don't know if we would have done that outside of that. Oh, but when you do radical participatory research and design, you don't worry about empathy, because you have what I call auto self-empathy. You see, those students in the International Summer Service Learning Program aren't creating personas of other people out there. They're creating personas of themselves. How powerful is that? Number four, the best way to truly do trauma responsive design, it's more readily embedded when you do radical participatory research and design. Now, I'm not going to go too much into detail, but the 6 components of a trauma-informed approach you can see match up quite well when you look at peer support and collaboration and cultural, gender, historical issues. So when we were doing the International Digital Literacy Project, we were able to observe people without re-triggering or re-traumatizing them. Why? Because we had people on the team who had been there before. Number 5 is more easy in research through design, and design through research is more readily embedded. Well, why? What do you mean, Victor? I mean that people don't have all these methodologies in their mind if they're not in our same field. They just do things. So yeah, you might be doing research, but community members may want to do design as part of the research, or you might be doing design, but they want to do research as part of design. Well, what does that mean? It means that the nonlinearity of the process comes and is driven by the community. So yes, if I do design in the design phase, I'm doing it to improve a prototype. But when I do design in a research phase, yes, I'm doing it just to learn. So it's a throwaway prototype, but it still comes out. It comes through the process. So in the International Digital Literacy Project, we had people that were designing in the research phase in order to elicit a response and to learn what the community wanted to know. Number 6, systems practice is more readily embedded when you do a radical participatory research or design process. Well, what do I mean by that? without going too much into social science theory, but there is theory, feminist theory, indigenous theory, womanist theory that says, it says a lot of things, but it's called standpoint theory. People at the bottom of a social hierarchy have a knowledge advantage. Now, people don't like for us to say this, but it's true that sometimes when you're at the bottom of a social hierarchy, you have to understand the will, the thinking, the volition of the people who have power in order to navigate through that system. But if you are at the top of a system, you don't have to understand the motivations, the desires of people at the bottom of the system in order to be a part of the system and to thrive. And so I have a project in North Carolina. It's a project that's focused on generational racialized trauma in the rural South. Did I go in? Did I tell these people, hey, we're going to do this methodology? I don't do that. Not in radical participatory research and design. They choose it. But what kind of methodology did they choose? They chose a systems methodology, and they created a systems map to look at the dynamics that were affecting and causing this, not just generational, but transgenerational trauma to continue on and on in the community. It came from them. I'll give you one more. I don't want to talk too much, but pluriversal and futures design is more readily embedded when you do radical participatory research and design. What do I mean by pluriversal? Can we get away from a universal understanding of anything like research, or specifically the good life? Can we have an understanding where all the countries in the world move forward and march and develop without having each one to establish a McDonald's in it? Can we move away from a damage-centered, problem-based, deficit-based, need-based model all the time to more desire-based models, where it's not always about solving a problem, but sometimes it's about reaching for a future or a goal or an ambition? This is a little bit more what I mean. And so when we had the International Summer Service Learning Program, the students were building pathways of how this program should work, not based on problems with the program, but based on who they wanted to be when they grew up and what they wanted to become. All of this sounds nice, Victor. Yeah. But how do you do it ethically? What are the ethics of it? And I could talk ethics all day long. I'm not going to talk too much about data and privacy and confidentiality. We can talk about that at the reception. Specifically, I want to focus on two things: equality and equity. We know in disability studies, gender studies, et cetera, that if two people are doing the same job, they should be paid the same. Call that equality. We go further as well, and we talk about equity. Because oftentimes community members are giving up time away from a job or two jobs or no job, but time they could be using to find a job. And we're just doing it as our job. So the time is more valuable to them than it is to us. And in that case, equity says to pay them more. So we failed in the International Summer Service Learning Program. We didn't pay the students. Oh, yeah, Victor, but you and the other professional researcher and designer, you weren't paid as well. So it was equal. Okay, we weren't paid as well, true, but it was unethical. We should have paid the students. But listen to the voice of equity. The effect of not paying the students was greater on the students than the effect of not paying the professionals was on the professionals. So that it's inequitable. Well, Victor, I know California, University of California system has a lot of money, but we just, not in my department, not in my program. I mean, I just don't know how to compensate people. Well, let's put money aside for a second. I want to talk about the digital literacy program and the multiplicity of ways that we compensated them outside of money. Every day they received breakfast and lunch. If we had an event at night or we were traveling, they received dinner. All their travel, room and board expenses were paid. If they wanted to become a first-time author on an academic journal paper, they could, and not everyone chose to. If they wanted to become a second-time author, they could, and not everyone chose to. They could receive referrals, recommendations, references. Every time I came back to that same region to test out a new educational product or service, they were called to be part of the first group of people to be there. The point here is that not that, okay, cool, I don't have to worry about money, I'll just compensate them other ways. The choice should never be yours. It's theirs, because they know what's valuable to them. And if you don't know, money is the most flexible thing because it can be used to purchase what they want. Ultimately, the question before us is, how do we know what we're doing is truly radically participatory? Some people ask me, well, Victor, why does that matter? Why do I care about that? Because the whole point here is that justice isn't just about the outcomes, but it's about the process. And if you have an unjust process, you've already negated the outcomes. So we ask one question and one question alone. have a majority of team members experienced a sustained and sustainable shift in power. Let me say that again. Have a majority of team members experienced a sustained and sustainable shift in power? So if you look at the International Summer Service Learning Program, the answer was no. The power dynamics were exactly the same at the end of the project. In fact, when we delivered this new design and prototype of the curriculum and the service and the program and the technology, the nonprofit said, "Ooh, I don't know, I don't like that." No. In other words, what they were saying was that, "Oh, you thought you were doing radical participatory research and design. You thought we had let go." No, we were just hiding and waiting to see what you would create, because if we didn't like it, we were going to usurp power and come back and take it. And so we were in a bind. We basically took the design that we created and we treated it as what we call in some design circles a design future. This is something that could happen 10 years from now. And then we did a method that we call backcasting. What are the different versions of this program and curriculum and technology that we would have gone through across the 10 years? And then we said, what's the first step in that direction that they would be okay with as well? So we had to do this process to kind of create something that they would be okay with. In contrast, I want you to think about the International Digital Literacy Program that involved, visual, graphic, content strategy, information architecture, UI, UX, so all the technology design, but also program and service and process design. We had hundreds of thousands in Bangladesh who reached a particular level of digital literacy, tens of millions of women in India that reached a particular level of digital literacy, tens of thousands in Colombia, thousands in South Africa. I can go around the world. But ultimately, I want you to look at the team members. One of them became a project manager, another a product manager, another a designer, another an engineer, another was already a designer, but he received a promotion. Another said, "I don't care about this. I love selling flowers. I'm going to keep selling flowers. That's my idea of a good life." And his business improved. In fact, I brought in 3 people from my multinational corporation who were not data scientists, product managers, designers, researchers, engineers. They were marketing and salespeople. Every single one of them quit their job by the end of the year, and they knew they were going to do it by the end of this project. I, Victor, quit my job by the end of the year, and I knew I was going to do it by the end of this project. 100% of our team experienced a shift in power, whether releasing, letting go, or assuming more power. And so let me leave you with this. In futures work, future studies is a discipline. It's you can get a degree in it, and it's something that we do sometimes in design. We sometimes create what are called forecasts, and not predictions, but they're things meant to provoke you and for us to decide, do we want this or not? So imagine it's the year 2034, 10 years from now, and the United States government issues a new law and it says, look, all government products, services, and policies must be created through radical participatory design and research with the community. This ushers in a new future of the future of work, in which people from all walks of life come into the government and begin working on government products and services and policies. It's great. And one of these teams, some of them stay in government, others take their new skills and get new jobs with it. But one of these teams then ends up creating a new law called the Planet-Centered Value Creation Law. And this law says, above all things, that not only the government, but any nonprofit, university, public institution, private company that has products or services for people in this country, residents or citizens or immigrants, must use radical participatory design. Whew. Companies are upset. Like, normally we lead the government. Now we're behind it. Oh, I don't know what to do. So they start doing this. But some of them do what looks like radical participatory research or design, but it's really colonial participatory research or design. Now, with the forecast and futures work, we ask ourselves, is this a future, or are there components of this future that we prefer? And if we prefer this future, or if there are components of this future that we prefer, what steps are you going to take? What strategies are you going to make? What strategies will you employ to make this future, or the components of this future, more likely to happen? What are you going to do? I'll tell you what I'm doing. I'm not just working at the project tactical level. I'm working at the meso scale and the macro scale as well. So I've built or published a policy memo for the federal government, and I've taken this to the White House, and doing what's called policy entrepreneurship to kind of get them to implement this about radical participation in government policy, products, and services. I've started a participatory community of practice within the federal government of people to draw more awareness. I'm working right now on participatory government awards to highlight people who are doing this and to encourage more people to come. In other words, I am trying to make it a reality. And the question before you is, what will you do to make that a reality here? Thank you.
Thank you, Victor. I hope you guys can all see why I was so excited to have Victor here as a speaker. That was a great talk. I'm Jonathan Prue. I am the Interim Deputy Director of the Design and Discovery Team at SomTech. Thank you all for being here. I'd like to invite our Victor and our panel members to come up to the stage here, and I will introduce our panel members. Our first panel speaker is Dr. Urmimala Sarkar. Dr. Sarkar is a professor of medicine at UCSF in the Division of General Internal Medicine and Associate Director of the UCSF Center for Vulnerable Populations. She's a general internist practicing at the ZSFG Hospital and Trauma Center's Richard Fine People's Clinic. She's an associate chair of the Department of Medicine and a member of the Helen F. Diller Comprehensive Cancer Center. Dr. Sarkar is an expert in digital health equity and learning health systems research, focusing on outpatient care for marginalized population. She has a methodological expertise in qualitative and quantitative implementation sciences methods, randomized controlled trials, and observational health services and health communication studies. Her current NCI-funded work includes observational mixed methods work on best practices in survivorship care and developing and testing multi-level health system intervention for completion of colonoscopy among those with abnormal stool-based testing. Previous NCI-funded work includes a social media intervention to promote HPV vaccination, as well as a mid-career mentoring award. Please welcome Dr. Sarkar.
Thank you for that very comprehensive bio. I'm very inspired by that keynote presentation, and I can only aspire to that type of work. Coming from the very biomedically minded space that we're in, I wanted to share an example which I think is relevant to what you said, Victor, about backcasting. So thinking about where we want to be and maybe nudging people who come from a very different ethos one tiny step in that direction. So with that, I'm going to share an example. All right, these are disclosures. Okay. So I do a fair amount of work with the private sector. And the reason that I do this is because at San Francisco General Hospital, we care for low income, racially, ethnically diverse, sometimes non-English speaking populations who can really benefit from innovations in care. And yet, when these innovations are designed, they're often not a fit for our patients or for my community members, as examples. And so in an effort to try to bridge the gap between what is needed and what is available, Solve Health Tech is an initiative within the Center for Vulnerable Populations that partners with companies, convenes with stakeholders, and tries to bridge the needs on the ground with what's out there. So I am one of several Solve leads, and I'm going to share a piece of work that kind of happens after the design phase, right? So we don't always have a hand in the design of the tools that are out there, but we can demonstrate how well or how poorly they work for people. And this was a very small project. It was actually funded by the FDA. And we were already working in partnership with a private company that uses virtual reality for pain management. And this was already FDA approved. And this company came to us to ask, why is it only that very advantaged populations are using this tool? And we did some work for the company to try to help them understand the system of care in the US safety net and how that was implementing or how that was affecting their ability to implement this innovative tool for people who actually have the highest burden of chronic pain. After that, they came to us and said, well, what if the FDA actually said, we've just approved this tool. Can we see how well it works? Not in the most advantaged populations. So that's how this project came about. And I'm going to show you what this graph shows you is kind of a very simple measure of how well people could use this tool. So what we did was we invited some of our patients who have chronic pain to come and test the VR tool. And the first thing we wanted to know was, could they navigate it? So in the blue bars, which are actually quite high, are the proportion of patients or the number of patients who were able to go through each of the 3 modules. So I'm only showing you one example because of limited time, but this is actually really excellent performance compared to many of the digital health tools that I have tested out with our patients in the past. In general, these patients with chronic pain, we gave them the headset and said, hey, please go through this chronic pain module. They were able to do it. So that's the thing. They could complete it. And then we talked to them more to understand how to contextualize the potential acceptability of a tool like this. So our participants were very motivated to try anything because their current pain management strategies were suboptimal. And we know that chronic pain is one of the most terribly and tragically undertreated conditions in this country. So this was not surprising. There was a high degree of motivation, and that translated to a willingness to try a new tool. Most of them said, I would definitely use this in the future, as long as you don't take anything away from me, because I'm barely managing as it is. Oftentimes, the argument around these types of tools is they're safer than X, they're better than Y. And we have to really think about how our patients are resourced and situated, and the challenge of trying to take anything away. And then they had, as design participants always do, very pragmatic suggestions to improve usability. Make it lighter. And then something that I hear no matter what tool we discuss with our patients is you need people, right? In this world of technology and digital health equity, my number one lesson from every single study that I've done, not just this one, is that having a person there to introduce a new technology and familiarize people with it is not a nice to have, it's a must have. So that's the other big lesson that we took from this very small usability exercise. All right. We wish that there had been the opportunity to do participatory design from the beginning in those modules. That was not there. I think that it's harder to go backwards, right? And some of the feedback that our participants had were things that in retrospect are really hard to go back and recode and change that would have been much simpler to do upfront. Usability testing is a really key part of the process, and it's part of that non-linearity that you were describing earlier, right? Like you need to do testing and iteration. There are universal design principles that are rarely used in the commercial space, in my experience, but they're out there and are very accessible. And then I hope that this project makes an argument for academic and industry collaboration to be able to do the kind of iterative improvement we need to make technology and digital health in particular transformative and not just incrementally beneficial. So I think I'll leave it there. And turn it over to the next speaker.
Thank you, Urmimala. I'd now like to introduce Dr. Jarmin Yeh. Dr. Yeh is an associate professor at the Institute for Health and Aging, Department of Social and Behavioral Sciences in the School of Nursing here at UCSF. Their research broadly investigates social justice issues that impact the quality of life of community-dwelling older adults, people living with dementia, and caregivers. They serve as co-director of the UCSF Emancipatory Sciences Lab, are affiliated with the UCSF Philip R. Lee Institute for Health Policy Studies and UCSF Bioethics, and teach in the UCSF Master of Science in Healthcare Administration and Interprofessional Leadership Program. Prior to joining UCSF, Jarmin worked at the New York Academy of Medicine's Social Work Leadership Institute, where they managed a national initiative funded by the John A. Hartford Foundation to bolster the social work workforce in aging. They serve on the board of directors for the Meta Fund, Community Living Campaign, and Head Over Heels Athletic Arts. A retired gymnast and former student athlete, they still perform the occasional cartwheel.
I'm gonna do one right now.
You got enough space, right? Please welcome Dr. Yeh.
I'm always too short behind these podiums. So I'm Jarmin Yeh. Thank you for the very nice introduction. I spend a lot of time thinking about aging. I am an environmental gerontologist and a sociologist. So what that means is with environmental gerontology, I think about how, over the course of aging, our physical and our cognitive capacity changes, and our ability to integrate and perform the things that we need to perform or want to perform in our environment changes. And so environmental gerontology is sort of a functionalist theory that tries to identify the best person and environment fit. As a sociologist, I have a bit more of a critical critique on this take of environmental gerontology. In sociology, I'm really thinking about the ways in which social institutions, social structure, and social networks influence the way that society can cohere or not. And so it's really sort of two converging trends, population aging and urbanization, and the confluence of these trends that have brought me to thinking about aging in the modern world and bringing environmental gerontology and sociology together. And so we were asked to think about like a health equity project that we'd worked on that incorporated some design features. And I've been spending, I want to say, about the last 15 years thinking about some of the work being done largely right now, spearheaded by the World Health Organization around age-friendly cities and communities. In 2007, the World Health Organization came up with this sort of global network. They wanted to create a global network of age-friendly cities and communities, and various cities and communities around the world were sort of taking this up. And I think Victor made a really good point. Like, people have been designing communities since before we had the words for participatory design. But I think the central tenet to the WHO age-friendly cities was this idea that we would start with community dwellers and city dwellers and older adults to better understand how do we create communities where people can grow up and grow old in. And so I guess I have sort of two examples of projects I've worked on here in San Francisco as part of the Long-Term Care Coordinating Council through the mayor's office. For about 6 years, I was part of a working group that was thinking about how to make San Francisco more age and disability friendly. This is entirely a community-led group that was trying to talk with different city government agencies about how do we think about things like housing, transportation, social participation, civic engagement, health and information, different domains of what makes an age-friendly city livable for San Franciscans. We had tremendous momentum. We did lots of sort of listening sessions and focus groups, all community-led in the community to gather information. It culminated in this really fun event that we called a Party with a Purpose that was deliberately held at the public library. We had entertainment, we had language translators, we had ASL translators, very inclusive, and all of the design elements that that were built into the event were very, very much community organized and community led. We even had a award for the first age-friendly sort of champion, and that was the SFMTA, who in that year had come up with free Muni for older adults and people with disabilities. So that was a big win from some of the advocacy that folks in this group had done. And we had lots of momentum for what was to come next from this very community-driven project. Soon thereafter, the city hired someone to take over this whole endeavor, and then it became a city project, and all the people that were involved for 6 years and beyond were disinvited from participating again. And so things kind of fizzled out. So that was the end of that project. The city still has its own work, but it has a much different feel and tone than the origins of that project. The second example I'm going to give is it was a class that I was a part of. I was one of the facilitators. It was with undergrads at UC Berkeley and also older adults, part of the Ashby Village. And so half the students in the class were undergrads, and the other half of the students were older adults from the community. And it was a co-design class called Navigating the Human Path. And I have a short video just to show you a little bit about kind of what came out of it. Is there a volume on this?
There is. I think you have a question for there.
A lot of people with tech in their title, so I feel like someone should be able to.
Really seeing the models up to now don't fit. We're going into a brave new world here.
The class is a lot about co-design, so not designing for someone, but designing with someone. Everyone at every stage of life is teaching. No matter how old or young, we all want to connect more, want to have more opportunities to engage with our society, with the community.
We want to take people from the community to work on problems of the community. So we brought together a bunch of volunteers from the community and then 16 upper design students trying to put together a design program. And we came together to see what could we do around transitions around aging.
We shouldn't segregate ourselves by age and experience. Through design, what I'm learning is that you can really bridge that gap. You know, you can work on things together that benefit both groups, and it brings us closer together.
When you're designing things, you should be thinking of other people. You shouldn't just be closed-minded and thinking of the things that you would like for yourself, but kind of engaging yourself with a very diverse audience.
So this class is possibly one of the most interdisciplinary in nature, going out, taking that field trip, putting your solution out there and letting it be like shot by the public.
What we're trying to do here is take co-design to a whole new place. And to do that is to change who ultimately makes the decisions about what is the design. What do we go after? What do we put forward as a recommendation? And hopefully also to control some of the process of how it comes out at the end, it gets into the world.
I'm going to take away from this is to go back, set up design teams within the communities we manage and within our team members who actually service these communities of how to make changes. Regardless of age, we have some of the same issues that need to be solved. And if you can solve it for seniors, you solve it really for everyone.
And I'll just stop there and pass it to the next speaker.
I'll introduce our final speaker, Dr. Jennifer James. Dr. James is an associate professor in the Institute for Health and Aging, the Department of Social and Behavioral Sciences, and the Bioethics program at UCSF. Jen is a qualitative researcher and a Black feminist scholar who conducts community-engaged research at the intersection of race, gender, and health. Her research interests include cancer, aging, end-of-life care, patient-provider relationships, health decision-making, and reproductive justice. Her current work is focused on experiences of health and illness for people who are or have been incarcerated. Her work is informed by her background in social work and social policy. Please welcome Dr. James.
Thank you so much. I think it's good that I'm going last because I can just say I don't know what I'm doing in this space at all in so many ways. I first heard as a term, I don't have any slides. Yeah, perfect. They said 5 minutes, just talk. So that's what I'm doing. I first heard last year, I gave a talk and a med student was like, I liked what you had to say. This kind of sounds like design work. And I was like, interior design, graphic design, what are you talking about? It was brand new to me as a concept, but as someone who does work in communities, who does collaborative research, the more I've learned about it, the more I've thought this seems like there could be possibility here. And I have a really strong desire to learn more. And I did not title sort of my remarks, but if I did, I think I would title them like everything Victor said, but oh my gosh, this seems really hard to do at UCSF. How do we think about this and do this kind of work in our really particular environment? So I've spent the last about 5 years doing research on incarceration. That's sort of when that area of research really started for me. And I started with a very top-down UCSF, like got some pilot funding, said, will you write me a letter of support, random organization I've never talked to before, so I can come in and do some research. And they were like, sure. And over time, been able to sort of build, to have relationships to now, put in grants collaboratively to do work that is sort of co-created and newly put in one with design, which again, I don't know what that is totally. I'm figuring it out, but we'll see if it gets funded and we can learn more together sort of with my partners. And there's a lot that I think about as someone who I want to learn about new tools to work with people, with patients, families, community, workers, policymakers to advance new understanding and solutions for what are some of our greatest challenges, but some of the really most basic fundamental challenges in our society. So like Victor expressed, when I think about research and including my own research, I think a lot about how it's inherently quite extractive and vulturistic, very top down. And in my work in particular, because of what I study, there's an element of what I'm doing where I go in and really take people's trauma and share it out with others for my own gain. And, I do it, it's a tool I use really explicitly with the idea that if we tell people what others in the world are facing, hopefully they will gain more empathy and understanding and want to advance policy and think about things differently. But I often think about, I'm asking people to share their trauma with me so that I can get grants and publications and promotions and recognition. And that's really icky. It's really ethically troubling. And it's the sort of the world we live in. And I wrestle with it and don't really have answers. And this idea that we sort of come in and we take is something I've heard throughout my research career when I was doing my dissertation and I was much, much younger. I was studying Black women with advanced cancer. And a lot of people who were willing to be interviewed by me were these very nice older Black women who were like, well, of course I'll help you with, we'll make sure you get an A on your paper. They wanted to help me. They didn't think that my research would do anything for them, but they were really nice and wanted to help me with my assignment in school, because I think they thought I was an undergrad, even though I was much older than that at the time. But it's a thing that I heard in that work was, someone I remember saying really explicitly to me, oh, sorry, I touched this computer. Yeah, I'll do this for you, but I know that it's not going to do anything to help me, but I'll do it for you. And that was like hard for me to hear as a very early career researcher who thought my work was going to change the world, as we all do when we're embarking on this journey. But like, of course, she was right. None of my work did change anything meaningfully in her life. Maybe it still will, as I still struggle to publish from that project. But I'm not going to cure cancer. I'm not going to end health disparities. And I'm aware that like my research is small. And so what do we do with that? Recently, it's been a conversation I've been having in different communities and hearing the sentiment of we're over-surveyed, we're surveyed to death. Someone in a project we did said, I could paper my house with all the surveys I've completed for you. Nothing ever happens after you do your research, and trying to think about the paradox of both experiencing that as well as experiencing people who look to me, who see you're a UCSF professor, that involves power, and want to collaborate with the hopes that I can really do something and existing in that space. And I'm going to share a quote from an interview I did because it is something that really rocked me and I think has made me think about how I'm doing this. So there's some swearing in this. So earmuffs if you don't want to hear swearing. I was talking to someone as a part of a project on incarceration and health. She had just finished telling me the names of the friends and loved ones that she'd lost inside, people who had been killed by the system of incarceration. And she's saying, I wasn't sick when I came in here. You being doctors, you healthcare, you motherfuckers didn't take care of me. Feed me bullshit, let mice and everything run around, shit in the food, shit's all in the kitchen, roaches, all this. You think you give a fuck? They don't care. We took better care of each other than the medical department. We took better care of each other if they did anything. And they got the taxpayers out here thinking they're taking care of us. They ain't doing a motherfucking thing. That's it. Is that what you want to know? That's what she said to me. And I said, no, I don't want to know that. I don't want it to be reality. Thank you so much for sharing it with me. I was very flustered. I didn't know how to respond because it was such a moving conversation. And she said, it is reality. It's reality. And this ain't no bullshit, and don't take this the wrong way. But every time someone talk to us and tell us they want to help us and they want to do this shit right here, this interview, they don't get a motherfucking thing, but get the glory for having a fucking interview with me, a convict. And that's it. We raise the money. We send our friend boxes and Bibles when their Bibles are raggedy. We keep money on our phone and do emails and shit so they feel like they know somebody loved them. And so I conducted this interview as a part of a project that was done in collaboration with community organizations. I had a specific co-investigator who designed this research with me, who was from this community, who served time with this person, right? And was in the room in this interview. In my mind, I was doing everything right. And this statement was really impactful, that she was willing to tell me both that she associated me with the same systems of power in our state that harm people every day, with the correction system, with the medical system, and also that she knows that there are limitations to what we were doing. And she's telling me what they need. Like, they need support to support people inside. They're giving their money and their time to do that. How do we do that? And how it makes me think so much, and has made us have really good conversations on our team across academia and community about health equity and community engagement, and how we think about it, how we talk about it with people inside and outside of the institution, to make sure we're able to do research that is meeting the actual needs in the moment of people, in addition to serving some of these longer term goals we hope to do with research. And so just a couple big concerns and thoughts I'll lay out and then I'll stop. My big concern in general is that we still think about health equity work and community engagement as a solution to the problems of our research. We think about it as a way to educate the community about why they should think what we is important, as a way to recruit participants who haven't traditionally been engaged in research, as a way to validate what we want to do. I got these community members to sign off, therefore my research is good. And that really worries me. And then on the flip side, I worry that we make community engagement, working with humans, an exceptional act. We fall into this idea that only people who look like the community, whatever community means, community often becomes a synonym for poor and of color, when of course we're all a part of communities. Only people who look like the community can be in the community. We can only invite people in if we have it all figured out, if we're prepared for the situation, or that you have to have a certain type of knowledge or expertise in the community to be able to be let into this space. And so much of what I do is spending time with people and building relationships, in a lot of ways doing things that are similar to the service work we all do all the time, right? I sit on committees and I write reports and I do public engagement and I do lit searches and I develop PowerPoint slides and I help with fundraising and I help with ordering coffee for events. It's all these things that we do all the time at UCSF. And we can also do that for organizations that aren't bringing in millions and billions of dollars a year. They're skills that we have. We have the tools needed to do work in partnership with people outside of academia. And this is both a critical part of being in community as well as a critical part of the research process of learning what people need and seeing and creating avenues to develop the research practices and protocols and questions to get there. But we need new strategies and methodologies, and importantly, resources to do this work with communities to co-develop solutions, to find ways to make sure we're not telling communities what they need or wringing our hands about why won't they trust us. We can't assume also that community have all the answers and we just need to ask the right person. We can't make it their burden. But we need new tools for this collaboration, for radical new understandings of knowledge production, to reevaluate ideas of impact and who our research is reaching, and really to develop new flows and understanding of resources and better ways to co-develop solutions. But what's hard is feeling like our system really isn't built for this. It's really hard to get a grant to fund research if you don't know the aims of the research, the design of the research, what you will do, how you will spend the money. UCSF has some more models for this internally, small grants, which is fantastic. But even when I submit one of those grants, I have to be the PI, right? Because there isn't a way in the mechanisms to put someone who doesn't have a UCSF department and a grants manager as the PI, right? It still has ownership with me. UCSF, speaking of ownership, gets to decide who owns the data. It's not easy to make that a thing we decide collaboratively or to decide the community owns it. UCSF decides what is data by controlling the IRB, decides if we can hire someone, which is really hard if we want to hire someone with a criminal background or without a bachelor's degree, decides if we can pay people cash or not. Our buildings are locked, like even to get into the library now, post-pandemic, you need an ID to get in. We decide who has access to our spaces and to the knowledge we co-produce. And so I want to learn more about how design can help us to do this work and how we can create an environment at UCSF that allows for radical new ways of knowledge production. Because I feel like it's not what it's been built for, but it's necessary if we want to really intervene and work towards health equity together. So I'm hoping everyone in this room will tell me how to do that. Thanks.
So apologies in advance. So we exchanged questions, kind of thoughts about what we might talk about, but I generally try to go with the direction and flow. So I may ask things that we didn't discuss. The first thing that comes to mind is, what are the special considerations to be aware of when you are doing participatory work with different or certain populations, like older adults, Jarmin, or people who are incarcerated or have been incarcerated, Jen, or even when working collaborations with industry, or patients or kids? Are there certain considerations that we have to be aware with that might be different when working with other populations?
Can you hear me? Okay. I'll just say what you said about having a team. To me, if you get there, if you have an inclusive team that is flat enough that people will tell the leaders when they're messing up, right? So you can't just hire someone who comes from that community that's truly bicultural and bilingual. Just as an example, they have to feel like they can say when I'm wrong. And that takes a lot of work. Yeah.
Say something, I mean, there's so many things with the criminal legal system that come up that are really, really challenging. The levels of permissions that are needed to do collaborative work, that you have to engage with structurally violent institutions to get permission to go inside, which changes the questions you can ask, which is hard. Things about privacy, anything that you send inside a prison is not confidential. If people speak or say something or do something, that can have retaliation for them, which can be really concerning. Am I putting someone in a position where they could be additionally vulnerable because they're working with me, is something I carry a lot. And for me, so much of it is based on like having relationships with people who know this well, who have this experience, who can speak to navigating this power, and who can help me. A big lesson I've gotten over the last year or so is hearing from people in all sorts of communities who say, like, let us decide. Like, you think this thing is too hard, or no one will want to go to this place, or we wouldn't do it for this form of compensation, or we're putting ourselves at this risk. Like, just ask us and talk to us about it. We're adults. I always work with adults who can make those kind of decisions for ourselves. And I think I have a tendency to want to protect people in a way that I think is paternalistic. And that's something I balance a lot as well.
Is this working? Yeah. Okay. I think in thinking about working with older adults and people of different generations, the way we experience time is really different depending on where we are in our life course. And so I often find that I need to, the time schedule I'm on is very much institutional time, bureaucratic time. I have to go fast. I need to respond to emails within 24 hours. I have to be reachable all the time. And when I work with older adults, their experience of time is much different, and I have to go slow, and doing slow science becomes really important. That's, I think, beyond just like relationship building, but just kind of the time it takes to listen, meet them where they are, go through the day at the pace that works for them and not at the pace that works for me, which is, oh, I can fit you in between this 30-minute meeting and that 30-minute meeting. Like, that won't be an appropriate way to work with them in any projects. And I think, in the video I was sharing too, with undergrads, they're on their own time schedule as well. And so trying to find a balance between the ways different people experience time to do a co-participatory project can be a challenging thing. I think the other thing too, I have another example of a project I'm working on with some community-based organizations here in San Francisco, and we've developed a adult day program within for LGBTQ older adults, and just thinking about, being really deliberate from the beginning that it was a co-governed process for everybody involved, including the participants that were, really informative to the inception of this idea, to the implementation of the idea, to now, it's a couple of years in and trying to see where it's going to grow and expand to. But I'll give you a specific example of something that came up between two participants. One was a trans Black woman who has a long history of experiencing stigma and trauma and being silenced and hushed in her lived experience. And there was another participant who was a white woman who identifies as a lesbian and also has trouble hearing and is very sensitive to noises in the environment and has some early symptoms of dementia. And so we were in the community group doing an activity, and everybody was laughing, having a good time, talking very loudly. And so one of the participants hushed the other participant because the noise volume was too loud. It was hurtful to her ears, and it was hard for her to focus because she's sensitive to sound. The person that got hushed took that very personally because her lived experience has been silenced and hushed, particularly by white people. And it escalated into a situation that we had to de-escalate. And that was a circumstance where, they're coming from their own standpoint, and that was, neither one of them was meaning to be hurtful to the other person, but we realized that we need to have repair circles when these moments come up, when we're trying to do something very collective, very communal, and there are misunderstandings that can still take place.
Yeah, that brings up a really important point related a little bit to what you said, Jen, about communities, and what do we mean by community? Communities are heterogeneous, they're different. So how do you deal with power dynamics within a community when working alongside a community on any of these projects in your research or classes or your emancipatory sciences lab, Solve Health Tech, your research, et cetera?
Yeah, I just did think it's such an important reminder that, like, of course, power exists everywhere, and there are shifting and evolving power dynamics and relationships and tensions and priorities. And I think we have too often a tendency in academia at UCSF to say, what does the community want, as if there's a singular community voice or opinion, or that any group of people could speak for the community, like capital T, capital C. And I've dealt with experiences in some of the organizations I work with where there was a fracture, and suddenly the organization, like, we were doing this work, it was going great, but now these groups of people over something unrelated to our work are no longer collaborating. So what happens to the work we're doing together? And feeling like I obviously don't want to pick sides in something that isn't about what I'm doing? How do you navigate it? It's tough. I don't have like good advice for that, except like I don't like conflict. It's really scary. But I think a lot of this work, I mean, it involves flexibility, right? Like I've had projects or papers or, grant opportunities that have just stopped because it wasn't going to work in this scenario. It didn't work for certain people. And like, you can't bulldoze your way through and say, well, no, we said we were going to write this paper too late. We're writing it. Or, well, the grant's due. I'm just going to put it in anyway. So you have to sort of adapt. And part of that is learning and building relationships and having people trust you. And I feel like one thing I've really felt is that if you're doing work that's truly collaborative and community-based, like you can't say that until someone calls you and says, what are you doing? You're doing it wrong, or I'm disappointed in you, or I'm upset with you for something, because that means that like you actually have a relationship that they can do that. So.
That's exactly right. You know you're in when you're being criticized, for sure. I'll just say, I think that different communities are different, right? And I've actually spent a fair amount of time in these communities that are very foreign to me, like among private sector digital health executives, for example. And I think status can be really fluid, right? So I am a person who, when I do work at San Francisco General, I've been practicing in the same clinic for 20 years. People know me, and I'm one of the physicians, so I have status. And when I go into an investor roundtable, and everyone is significantly older, significantly whiter, and significantly more male, I don't have those same bona fides until I establish them, right? So we occupy different positions in different communities, and there may be some places where I might be assumed to be a leader and assumed to be at the top of the hierarchy, and there are other places where I would be assumed to be very much not important, and that's always an interesting thing to navigate.
Yeah, I love how you flipped a little bit the question, because we talked about how we view communities. Are they homogenous or heterogeneous? But what about how communities view us? When you do the work that you do with people outside of UCSF, how are they viewing you and your institution? Do you represent the entire institution? Do they differentiate? And how does that affect the work?
I mean, I feel like most people think I'm a student. And so I think that they find that very unassuming. And so they think I'm learning, and I really am there to learn, but I usually get read as a student. So
is that helpful or unhelpful?
I mean, I think it's helpful in the sense that people are very amenable to help a student. They almost always think I'm doing a student project. They almost always think I'm an undergrad. So maybe that makes me feel less scary to them. I'm not sure. I don't keep hidden what my actual title is. I do share that, but I don't know. They still think I'm a student. So
I'll say when I started doing the current work I'm doing, one of the first times I went to an event that an organization was hosting, somebody was like, over here and was like, oh, you should meet Jen. She's from UCSF. And the person did like a full body eye roll. They had like no interest at all in talking to someone from UCSF. And I was like, oh no, but mostly that it's been fine. But I have seen that, especially in communities I think are heavily researched, like there is you have to sort of be as individual people who come in with a strong, there was a meeting one time where somebody else referred to me as Dr. James, and someone was quick to be like, you should call her Jen, like shut it down. Or somebody would say ask me for my expertise, and people quickly saying we take the expertise of people with the lived experience as more privilege, which I also would say. So it's interesting, sort of, it goes back and forth, right? And I think I spent a lot of time feeling like I don't want to take up too much space. I see other people taking up too much space, and I don't want to be like that. And so it took, people I'm working with who encouraged me to say we need someone to speak on this, and being like, Jen, you like to, you do it. You love a PowerPoint presentation. And so it, or realizing that like, oh, like we have a communications team at UCSF, like I can get media to respond and like, have someone send out a pitch and they'll write articles about a thing that's going on. Like, so finding ways to use the UCSF stuff for good, which I feel like helps with the like UCSF baggage and the baggage of just speaking different languages and having different priorities that come with working with people who aren't here.
Okay. I think, Urmimala, you might have talked about bringing in people earlier in the process. Trying to remember. Even times when we bring them in at the beginning, oftentimes we as researchers or academics, professionals already have an idea of kind of what we want to do, and we're asking them, what do you think? Is it okay? Do you have what examples do you have of the community starting with the idea and approaching you? And if it hasn't happened, how would that work? Would you be amenable to it? Could it proceed in that fashion where they come and initiate?
I haven't had anyone in the community approach me and say, would you like to do this thing? But I have had, for example, people from the public library, which is, I think, a gigantic step closer to the community than we are here at UCSF, to say, when people come in and they need help using the computers at the library, a lot of times they need help with the patient portal. They need to connect to their doctor. Is that something we can work on together? And I jumped at that chance. I would always jump at that chance. I think we have a number of standing patient and family advisory boards, and that's really helpful in terms of, they do say like, you should work on this. And what I want to. What I bump up against often is, no one's going to pay me to work on that thing. And in the soft money environment that we live in, I have to pay myself and my team with grants. So one of the things recently, we were talking to, I do a lot of work on health literacy. And so we were talking about literacy-friendly patient, like prescriptions, right? So people actually know how to take their medicines. There are some really good evidence-based instructions that exist. It's just really hard to get them printed on labels, which is a dumb thing that I've been mad about for the last 5 years. And we were we're presenting back what we learned from our study to our patient and family advisory board. And they said, why can't you fix the pharmacy at the hospital? These are all the things that are wrong with it. And those are just not things I can fix. So I do bump up against that quite a lot when I talk to people about the pressing problems that they're dealing with in their everyday healthcare journeys.
Yeah, and I can tell a story of this happening in a positive way. So when I started incarceration research, it was focused on aging, experiences of older adults and chronic illness, which is what I was sort of studying before and thinking about. And in conversation with, I was having coffee with someone, we were talking about what was going on in the organization and my work. And she suggested a totally different area. She's like, we're starting to do more work thinking about the forced sterilizations that occurred in prisons. We think this is an area where research could support. We've been trying to pass this bill for 2 years. It hasn't passed. We need to support people. And I was like, oh, that sounds really interesting. That's not what I do. I don't know anything about that. And it was just like in my head, I sat on and I thought about it. I did a little writing or thinking about it, reading more about it. And then I heard an academic talk on eugenics. And I was like, oh yeah, eugenics is a pretty big bioethics issue. I'm in bioethics. There's a way I could relate this to what I'm doing now. And found a grant opportunity. And I said, hey, what do you think? Should we put in a grant to do this? And they were amenable. And so over the next couple of years, we put in like 5 different grants, which all got funded to do this work together. And now we've been working on this research project for 3 years, and it's led to other future research because, wow, there's a mess and there's a lot of work that needs to be done. And it's led to a lot of advocacy. And so I think a lot of it was luck. It was like, at the moment when I was applying for this was 2020 and post George Floyd, and people wanted to study people, wanted to fund people who were studying research on state violence and policing and race. So it was a natural fit in a time where if this had come up 2 years before, I might not have been able to get funding and it wouldn't have gone anywhere. But I'm really grateful that I was led to this opportunity for what's been like a tremendous research area for me as like a person and a scholar, and also a really great opportunity to do collaborative work that's supporting real live humans in this moment, you know, years before the research is going to come out. So I'm grateful that I listened to the advice from community.
Almost all of my projects are because a community-based organization reached out to me and was interested in partnering, and them understanding that for them to also get more funding for their work, that establish some evidence base for what it is that they're doing is going to be important. I think one of the things that has been interesting and challenging with doing that work too is that many CBOs are inherently interested in trying, well, you know, they deliver programs, and that is what they're trying to do. And I'm a researcher and not delivering programs. And so sometimes the goals of what we're trying to do can be a little bit different. And so this sort of bi-directional learning from each other, capacity building becomes really, really important. There are examples where even the CBOs are serving the community, and that we're trying to involve them in a meaningful way too. And we have developed some projects and grants that were completely driven by the members that they serve to design projects. I haven't been successful in getting those funded. Those are often, I get told that they're service and not research. So maybe just rethinking how we package that for grant funding. But that's been, you know, one of the primary challenges I think everybody has addressed in some of the grants that we have to write. It's almost like you have to know the outcome to write the hypothesis and the aims. It's kind of like you have to sort of engineer it as if you already know what's going to happen. And if we're going to be truly participatory, we don't really know going in.
Yeah, one thing I keep hearing over and over again is funding and grants and things like that. And a lot of communities, actually outside of UCSF in the world, we exist, especially here in North America and the United States, in a kind of capitalist, even hyper-capitalist structure. So there are people in the public that I've met who have this mentality that in order for me to do work in my community, my neighborhood, et cetera, I have to go to people who have a lot of money that they gain by maybe doing bad things in the world or unhelpful things. And that's how it works. You get a lot of money doing that, then you can give money to people who don't have money to do good things in the neighborhood. What examples in our last 10 minutes or so do you have of working with communities outside of this type of funding structure where they're learning or exercising assets that they have within themselves without depending on money from outside people? Do you have any examples of that? Am I asking a tough question?
No, I think it's what's hard because there's so funding for us, I think, exists on a couple levels, right? So it's like I got some of this, like, you know, it's a foundation, therefore it is not evil money anymore, money, right? That maybe was evil before, to fund my time, which then allows me to work with community based on their priorities, their resources, their needs, drawing on their skill sets. But in some ways, I'm doing that like on the side. It's not technically a part of my day job, but if my day job's funded, then, you know, nobody at UCSF really has a boss. Nobody knows how I spend my time. I think technically my boss is in the room, but would probably not call herself that, right? So like it's a weird dynamic. And so I have found, I think, again, I think we have a couple big things at UCSF. One is many of us have to fund our own times. Like I don't, you know, we don't have a job, and our staff don't have a job if we're not bringing in money from somewhere, which gets into this really gross idea of how we spread around money in our society. But then I think that there's also this piece of wanting to fund people for their time, which is important, and we should always do it. But then trying to find ways that we can be in community. And again, you know, a lot of the organizations we work with, they have their own funding. They're bringing in funding. I had a community organization tell me recently, like, oh, you want to give us $10,000? That's not really worth our time to deal with the bureaucracy of UCSF to get that. We don't need that money, but we'll still work with you, which I thought was funny and says something about UCSF bureaucracy and getting subcontracts. But so I think it's money is a big thing, but not the only obstacle. And many organizations have the resources they need and are eager to partner with people who have a different language or have, you know, meaning speak to different types of people, speak science or speak policy or speak whatever, have additional skill sets that can be useful or additional connections, and that we can be a support to them rather than them being a support to us in the work that they're doing.
I mean, I have a not research example, but one of the CBOs that I work very closely with, we do micro grants within the organization. And so we encourage the members of the organization to develop ideas, learn how to write a mini grant proposal so that they can get their ideas funded to do projects that they want to do. And we've done 2 rounds of that, and that's been a really good practice. And you know, where I sit helping the organization is seeing these sort of little ideas and seeing if we can pull them all together in some way to ultimately get bigger funding. I think where I tend to struggle is scaling some of this work. At the micro level, we can do lots of great things and do it really well, but trying to scale it to the size of getting an NIH R01 grant is where that leap becomes really, really difficult. And I have not figured out how to do that yet. So if anybody can tell me, I would love that.
How many minutes do we have left?
We're all accepting donations for our work.
5 before we start question and answer, or 5 total?
5 before.
Oh, okay, so because I want to get some questions from you all. I just want to make sure we have time for that. Okay, cool. Can we talk about notions of scale, right? Because you just brought that up. Now, normally, what I've heard about scale, we talk about scaling up, you know, affecting policy and law, scaling out, touching more people. What other notions of scale exist? And have you been involved in with your projects that don't work in the same ways as that?
I don't know if this is exactly what you mean, but I think a lot about routinization. Like, can we take the things that are supposedly innovative and just make them every day? So that's a form of scaling. And we think about that in medicine with evidence-based medicine and how long it takes for evidence to get into practice. But routinization to me is the ultimate goal.
Anyone else?
I was just gonna say, I feel like scale isn't a word I use. I'm like, say more. I want to hear more about what you mean, because I think I maybe have examples, but it's not a framework that I ever use to think about my work.
Well, I'm responding to Jarmin's
I
point
know.
about scale.
But you said, I sort of scaling up, that makes sense to me, but I'm like, what other directions do you scale? So maybe you have ideas.
I don't have good ideas, but I mean, like, what I mean is, you know, at a micro level, I feel like some of the work that I've been involved with community is very participatory, very inclusive. It's not linear. It grapples with all the messy. It takes a long time. But then to scale it, to make it sort of fundable, it has to be organized. It has to be structured. It has a linearity to it. I mean, it doesn't need to, but it has to, into the proposal, it has to be more structured than the process that we started with. And then we have to have a bigger impact. And I think that that's where we tend to struggle. It's like, how do you prove change? Did we improve knowledge gain? Did we change behaviors? Did we change practices? So that scale becomes really difficult. And I think that's where some of the systems thinking comes into place, where, you know, when working particularly with older adults, you know, they don't always want to politicize their identity to be advocates. Like that's not why they want to engage. They want to have fun, they want to enjoy themselves, they want to spend time with others, but they don't necessarily want to be advocates, or, you know, and we don't have to label things like civic participation, but that's a little bit what we're asking when we ask them to participate in our projects and in these ways to represent themselves and others. And so I think that's kind of what I mean by scale, to take it like sort of beyond, like, we're just hanging out, having a good time, talking to each other, to like, now we have impact, now we have reach, now we're disseminating things. So that's.
So it sounds like you're implying that maybe some of our funders need greater scaling literacy to understand the messiness of the work that we do, so that they're able to. Okay, just check. You want to say something?
Well, you know, I have funding from PCORI, the Patient-Centered Outcomes Research Institute right now, and they are a lot about, they keep asking us when we meet with them if we're using any of their measures of community engagement, and whether our community members have filled out the readiness scale that their other grantees have developed. And, you know, for on this axis of engagement, and on that axis of engagement, how are we doing? And their own patient advisors have gone through extensive training and have become very much professionalized. And I find that a bit perplexing, right? Because what's happening is they're taking people who we are supposed to serve, and they're kind of forcing them to learn our language and bringing them into our spaces and making them talk more like us, and therefore we can work more effectively with them. Like, that does not feel like the point. And I don't feel like in this particular project, which is about monitoring blood pressure at home, that my asking a survey about the 4 axes of engagement is going to help me actually get people to take up this new behavior. So I think that on one hand, it's been really wonderful to actually be working with a funder that is focused on engagement. It's a first for me. It's a pretty recent grant. On the other hand, I'm finding that what I learn from community members and from my colleagues who are much more expert in engagement doesn't necessarily align with what this funder is asking me to do.
I was just going to say, I agree with that so much. I question a lot the sort of professionalization of like patient advocates and community members. I think the need for like measurement, or it didn't happen, like if you don't have a p-value, then you didn't really engage community or make a difference, is like so troubling. And I just think that like we need to find ways, and I think these are things that can happen, are harder to happen, or maybe it just feels further out of reach on a funder scale than they are on an institutional level. Like at UCSF, we could decide to make things not tied to that, to make our own evaluation not tied to these kind of measures, to sort of change the math there. And I also think, I was in a talk last week, I'm looking at Jarmin, who was also there to see if they remember this, but like there was this depiction of like the poisons of white supremacy, which like Google it, it's really interesting. It had all these things about like what are white supremacy culture. And there were things like professionalization and objectivity and all these things that I was like, wow, every single one of those words are how we describe science. And like science is a white supremacist project. The work we're trying to do, I think, is we want to be counter to that, but we're forced to do it within the confines of the white supremacist patriarchal idea of science and academia. So how do we, from within the institution, change that so that when we say, I just, in a grant I just wrote, I talked about, I think they want to know how, it was written in a way that's like, tell us how you're creating a pipeline to bring more people of color into the university, which is a thing I support. That's great. But what I really talked about, which is maybe what they won't fund it, is like, I really think we need to train people in the university to have the skill set to work with people outside of it. Like it takes training to know how to do research in a prison. And that's, it takes training to think about doing work differently. Like people who are never going to get a PhD in molecular biology are still valuable of learning skills to participate and collaborate with us, but we measure it on how many additional people did you get. Even at UCSF, when we talk about mentorship, it's like, how many publications did the person you work with get? Like, that's how we measure success, and not, wow, I made them feel better about themselves. So like, we need to think about really disrupting how we measure success in this work if we want to do things differently.
There's so many questions, but I want to open up to you all. Any questions you have for the panel? Conversation's getting very juicy. Okay, there's one. Okay.
Hi, first of all, I just want to say, wow, it's really amazing. And I have a few things. We do a lot of really, I'm Laura Julie-Flowski. I help lead the preterm birth initiative here, and we do a lot of work with community. And I wanted to bring up two things. One was what you were just talking about around metrics. So I think all of us that work with community know that there's a lot of people are like, so I did my research and I went out to the community and I told them what I did, or I had one focus group. So if you don't think metrics are good, how do you counter the fact that kind of the minimal connection, right? That the minimal, I don't mean connection, I mean a connection, but the minimal box, right? Because you're experts, you know that that's not really partnering, right? So if you don't want a questionnaire, like how do you suggest the vast majority that are just kind of barely checking, how do you move that needle? And then the second question I had was more around this issue of, on the one, having a community advisory board or something that where you've really worked with them on a number of things versus individuals who have participated in studies, they're out of the study, and having voice in how their own work is being used and what the next step is. And there's this real stress between, should you really be including them in your advisory board because they were really participants? So that was like a side note, but I would love some input on this.
I'm okay with including my participants in the synthesis and understanding of what we learned. I feel like that if someone pushed back, I would say, who do we think is more of an expert? I mean, as a clinician, we always know the patients are always right. I think that's fine for the second part of your question. For the first part, I would say I'm not an expert. I'm definitely a learner in this space. But one of our UCSF experts came and spoke to a program that I'm part of, the K Scholars program, Marisa Raymond-Flesch. And she talked about the continuum of engaged research and about how important it is. And this was a range of clinical and translational researchers. So if we can move everybody just one step further, so they're presenting their findings back to their participants before they're publishing them in a paper, or they're actually holding a town hall so people can ask questions. Like if we can just push them a little bit further, we're going to get to a better ethos. And I haven't thought about it like that before, but I think my feelings about people who are doing the engagement in kind of a box checky way is that that's better than nothing. Let's push them along. And if you go and talk to people, they will talk back, right? So that's how I've gotten, I think, more facile with this, even though I do rely on colleagues' expertise, is because people will criticize you, right? They will say to you what you are doing wrong. So even if they're only having one focus group, maybe if they do one focus group for their next 3 studies, they're going to start hearing about some of the shortcomings.
Yeah, I just keep turning the microphone on and off. I agree with lots of that. First, yeah, I think, of course, participants should, to me, like the line between participant and researcher and community advice, like those are all blurry and all the same. And I don't worry about that. And I readily have participants share with thinking about what we do with their data, how their data is being portrayed, how I'm talking about them. And, so all of that is a constant for me. So I think that is good. And we should do more of making sure people find themselves in how we're producing our research, right? Like, or it's legible to them. And then, yeah, I feel like I talk about this in like a way that's like full of contradictions and so many circles, which is both like, I think everyone should do community-based health equity research, but also like, it's okay if not all research is that, and we need to have higher standards for how we do this, but also there's no experts in this because the real experts are people who aren't here. And I like that we have more of a push towards this. We have, if you get this funding, you have to talk with this CAB. If you are getting this grant, you have to, like I like that we're putting in more requirements, but I worry really greatly about it turning into like the IRB where you just, check the boxes off, or, okay, I did my sexual harassment video in the background. Like we don't want it to be that, because if you're not authentic in wanting to engage and build relationships and work with, then you probably shouldn't do that. And I would prefer someone who really doesn't want to do that, but they're not. And I would encourage them to think carefully about the type of research they're doing. I think maybe there's a lot of research that doesn't involve humans, and that's maybe a better space for you if you don't want to have relationships with humans at all. But it's really hard. I think that I've been a part of work. There's other here. Kelly Taylor was talking about this work about how do we think about advancing standards for health equity or anti-racism or having certifications in this way. And I think those things are great, but at the same time, I also worry about someone being able to say, and now I am an anti-racist. UCSF told me so, because probably that's not true. So I don't have any answers except
Yeah, I don't have a good answer either. I'm a learner in this space as well. I have talked to a few CBOs who kind of groan and roll their eyes when they're asked to join yet another CAB. And maybe those are the people that are using them in more of that checkboxy way and not authentically engaging them. So there is that concern. And then, involving participants into some of the other aspects of research like synthesis and data analysis. I always put out the ask. I'm sometimes told, I'm not going to do your homework for you. That's why you're in school. So but I do try to involve them as much as I can in every step of the process. And that goes for some of the advisory boards I've asked older adults to be on too. They're not interested in serving that. And I think it goes back to the conversation about professionalizing these roles. I mean, they have to step into a very sort of bureaucratic professional space. It's very uncomfortable for them, and not all of them would want to do that.
Any other questions? All right, well, thank you. Oh, we got one.
There was a little hand I thought I saw.
Time for one more.
Hi, thank you. I'll be quick. I'm curious about how we might change the kind of structures that sort of determine the research questions in the first place. So I'm struck. I have been a subject as a chronic pain patient advocate, subject of research. I have funded research, but for example, the idea of opioid sparing, just to use an example from your talk, is very much something that's an outcome often determined by the system, not by the people who are being studied. So while I appreciate the idea of helping people use a VR device to, as an alternative, the kind of structure of the question in the first place has been predetermined. And in a way, that's often the case when you're talking about the power relations embedded in a doctor's ability to prescribe, et cetera. So curious if any of you, including Victor, have thoughts on how to change the kind of big mechanisms that structure the funding, the calls for proposals or the funding questions in the first place. Thank you.
I won't say too much. I'll just say that there's work in that space. So there's work in terms of decolonizing philanthropy and funding, et cetera. The main thing I'll say is that I often use a tree metaphor. I'll try to be really quick. The roots of the tree are ways of being. I'm not going to use academic terms. The trunk of the tree are ways of knowing. The branches are ways of doing or methodologies, and the leaves are methods. So oftentimes we try to do this work at the branch, the methodology level, but the problem is the ways of knowing and the roots, the ways of being are colonial, and colonial ways of being and knowing can never produce emancipatory or liberatory methodologies. There's another part that I didn't mention, the sap, the nutrients that come up from the roots and go all the way up to the trees. I call this our ways of valuing, our systems of value. Try not to use academic terms. And so those determine even the questions we ask to which we apply methodologies. So when I'm working with communities, I try to, everything is part of that heterogeneous community in terms of whose knowledge is being increased by this question. It may not be the communities. They may not. Is it even relevant to them? What are their priorities? What do they care about? All that kind of informs. So them being a part of choosing the research question is a part of what it means to be radically. Radical doesn't mean extreme. It means fully, completely. It comes from the Latin word radix, meaning root. But even you all talked about evaluation. What is a definition of success? Again, coming from the community, et cetera. Now we have to do a lot of gymnastics to make sure we can satisfy the people in our organization while we still do that. But you can bring them in early enough even to help define that, is all I can say.
I'll just say, I was on the funding. I mean, it's so hard. I think we need to dramatically change the NIH in really radical ways. And I worry that our incrementalist attempts, or the NIH's incrementalist attempts, ignore some of the realities. So like, there are more funding mechanisms now where you can only get this if you are an HBCU or minority serving institution, or your institution has gotten less than X amount of NIH dollars every year. I think that's great. I think we should have like a NBA draft model where the people who got the least funding last year prioritized or something, right? Like that's better. But it's a problem if those institutions don't have the infrastructure to support writing grants, right? They don't have all the people and all the grants offices and all the budget editors and all the whatever, and somebody who puts it, like, they don't have that there. It's really hard to write a grant. So you're going to have fewer people who apply, or they're going to be lower quality by NIH's metrics. Once they're funded, they don't have the resources to administer it. They don't have people on their campus who have this training in statistics and this training in whatever. Like, it makes it so it's impossible to do the science according to the predetermined standards. And I think it's the same with community. We could say, I think the NIH should devote this amount of money to only true community-led research, where the questions came from them, they chose the researchers they wanted to collaborate with. But if it's all based on the same model that's been funding UCSF so successfully for forever, then either UCSF is going to co-opt and say, hey, you, let's put in a grant, I'll get you money, but based on what I want to do because I know the language, or like the projects are going to fail by the standard we've set. So it takes like such transformational work. And I do think this is, again, a place where UCSF has power and money. We could say we are going to set aside X amount of dollars that we're investing in the community, and they can hire UCSF researchers to support the questions we want. UCSF gets how much in indirects every year? Millions of dollars. What if we said $1 million of that is going towards this work? Like, we could do that tomorrow, and that could help change the formula. And I'm looking at Tung. He, I know, wants more of a tax to do this on the indirects that come in. So anyway, I'm like, Tung, do it. But yeah, it's really tough.
I know there was another, no?
No, they were pointing to say that it was his question.
Thank you. Building community already.
Oh, no, I was going to say, I agree with our Tung. Find some money.
I'd like to just add one tiny comment. This is something Jen has said before too. I mean, changing structure, that's so hard, and the structure is so obdurate. But I think that, we having more of these conversations helps, and we all sit on review panels for publications and grants. And so in our own small ways, maybe we can push back and ask questions about the papers we're asked to review, the grants we're asked to review, and question, some of where, the methodologies and the tactics that are written in. So
yes, I think that's so important. Like, we talk a lot here about what's fundable or what's publishable, but like, we decide what's fundable and publishable. We all sit on the thing. So like, do it differently, everyone.
All right, let's thank our panel.
Hello again. For our closing remarks, please join me in welcoming back Dr. Tung Nguyen, Professor of Medicine and Associate Vice Chancellor for Research Inclusion, Diversity, Equity, and Anti-Racism.
I'm all nervous now because someone pointed me out as where the money is supposed to be coming from, and that's not true. This was a great discussion. I actually had some thoughts about some of the question that was going on, and even though I have these prepared remarks, I'm just going to take a tangent for a second. So I do community-based participatory research, which is this field of community-engaged research that's a little bit farther on the spectrum. And the sets of outcomes that we talk about, there are what we call project outcomes, like the things that typically what researchers talk about, like behavioral change or measure this, measure that. And there's a whole set of what we call structural and system and capacity building outcomes. And so I think to answer some of the questions that have been floating around is to think about it this way. We live in a society where I think obviously it's quite compromised, but we still have to live and work in them. And so that's how CBPR people have approached this problem. And I have an example where we actually collaborated with SomTech on a project that was a tech project with a bunch of community organizations. And we were like talking about like, how do we measure our outcomes and all this stuff. And then we hit on this idea where we were like, okay, so we were given all this money to do this thing. So we actually need to have some definition of project successes, right? We are accountable for the money that we got. But what is it that we really want, right? And the community organization came back and said, we don't just want project success, we want epic success. We want success. And it turned out to be this interesting thing where we gave the community organization some money, and they're like, no, we actually want to make sure that UCSF change as a result of this project. And I said, we don't have the money budgeted for that. And they're like, well, we're going to give you back some of the money to do this, which is really weird. Like we gave them the money to do the work, and then they gave us some of the money back. Someone said, we don't give them enough money. Like, we don't need your money. Here, take the money and change yourself. So I want us to think about every single one of our research projects like this, that what is the thing that we're doing and what's the capacity that we're building? And one of the things that I always say is workforce. One of the things that you can do in every project is develop capacity by looking at your workforce for doing that project. So, all right, that was just a little bit of a tangent, but I just want to start by saying thank you for your presence and participation in this important symposium. I'd like to ask the organizer, Jonathan in particular, to stand up, please. Organizers, and you're giving them a hand, which is what I wanted. Okay, thank you for doing this important work. As you can tell from my title, health equity is a major priority for me. As I've said, I've been doing this type of community-based work for about 20 years for health equity. You've learned about the strategies and the approaches for this work, as well as some nuts and bolts lessons, I hope. I want to close by reiterating a few key concepts and approaches. First, and I think this goes back to the whole structural issues, we live and work in a health system, and that broadly defined is our healthcare system, our research, our data, our payment, all that is incredibly inefficient and inequitable. That's just the system that we are in. Our healthcare costs, not including what we spend on research, is 18% of our gross domestic product. It sucks up 1 out of every $5 in this country. And for that incredibly expensive price, what we get is a healthcare system that is the worst among comparable countries in terms of health outcomes, which is the one that everybody cares about, in terms of efficiency, and in terms of equity. All right? This is the system we live and work in. Second, we won't get to health equity simply by doing business as usual. In a structurally inequitable system like ours, every intervention, every innovation should be presumed to lead to inequities, either foreseen or, more often than not, unforeseen. And third, to safeguard against this, we must explicitly have considerations of a health equity all the way throughout the project, from its conception to development, implementation, and measurements. I would argue that we also have to be very innovative in this regard, in the sense that we should challenge every single project. Whether or not they end up doing community engaged work or not is not the question. The question is what is your project doing to health equity or health disparities? If I have my way, that would be part of the IRB application. And believe it or not, I'll work on it. Because we want to challenge you. Like, yeah, you're going to develop this great drug, but what is it going to do to health equity if the drug is $200,000, right? We need to ask these questions as an institution, and we need to promote those questions among all of our researchers. Now, we work in an institution that prides itself on innovation and changing paradigms. So I want you to do a thought experiment with me. What if we were to say that we should stop collecting data or creating interventions for English-speaking white people? Because that's all we have been doing. Isn't it time to stop? Like, we've done it. We've done that. Stop doing it. If you have to do an intervention, let's start with one tailored for people of color and in other languages. Don't start with the English one. Okay? What if you don't have enough money to collect data on all the diverse minority people? Okay. Take the money and spend it on them, but don't collect any data on English-speaking white people. This is a thought experiment on you do. And what do you think people would say to that? Well, I imagine a lot of people would say, well, that's too limited. That's not generalizable. That's too expensive for a small minority group. That's what they would say. I get that all the time. I do a lot of my research in Asian languages. And my papers are always rejected at times because it's like, well, it's interesting, but it doesn't really apply to all the American people. As if doing research on English-speaking white people applies to all American people. They have I'll bet you none of them has ever gotten that comment back, right? But my answer to that is pretty straightforward. English-speaking white people are a minority in California, but that doesn't seem to stop us from doing all this work. So that can't be the objection. Of course, I'm not a radical. So I'm probably not proposing to do that now, maybe later. But here are some things we can do starting now. So the first thing, as I've already alluded to, is to make sure our workforce is diverse. The one reason to make sure our workforce is diverse is this. If our healthcare cost is 1/5 of our money, then let's make sure all that money goes to diverse people, right? If we could do that, that would actually go a long way towards solving some income inequities. That would go a long way to addressing the social determinants of health. I think about social determinants of health this way. I don't want social determinants of health to turn into the next health disparity. What that means is that we'll be doing research on social determinants of health and how they affect health for the next 10, 20 years. But we won't do anything about making social determinants of health better. Okay, that's what's happened with health disparities. That's why we're talking about health equity and not health disparities anymore. I think that if you were able to get all the Black people in San Francisco to work at UCSF, that would really raise their income level and help reduce a lot of the social determinants of health barriers. I'm not, just making a very simple point here. Why can't we do that? Secondly, about workforce diversity, though, is that we are all wonderful because we are who we are. But we are also, who we are also defines the boundary of what we know and our perspectives. So the only way to guard against the things we don't know and the perspectives we don't see and the unforeseen outcomes is to have a diverse team. And in addition, since cost and budget often drives our decision, and now I'm going back to the researcher's point of view, what's better than getting 2 for the price of 1, right? Getting a researcher or a research assistant who actually speaks 2 languages or who can be in 2 different communities is 2 for the price of 1. We should be valuing that. And since we are, and I also make the point that, and I do believe this actually, even though it's sort of a rhetorical point, is that it's easier to teach someone from any culture how to do the science than it is to teach someone who's really good at the science how to be a person from a particular culture. That's sort of my sort of take on cultural competency. It's like, yeah, it's a good idea, but why don't we, instead of worrying about cultural competency, why don't we just get people who knows the culture to come in and do the work? Second, we want to make sure that we define the audience for our work appropriately. So Somtech talks a lot about human-centered design. It doesn't mean some abstract human being that being human-centered, right? And if we don't define it, it usually defaults. And again, in this country, the default is usually a white man, right? If we work and live with diverse populations, design with them in mind, and if we collect data, we have to accept that if it isn't being collected from diverse groups, it's not good data. I don't actually like the idea that people are reporting on projects that are, say, 90% white and say, oh, yeah, this is a limitation. It's not, yeah, it doesn't include all these other population, but it's still good. We should report. I'm like, no, it's actually bad, right? It's not good data. I don't care how good a job you do with that data. Your sample doesn't apply to anything I care about. Like, why would I read your paper if I'm making policy? Why does that matter? You can have the perfect paper, and if your population is insufficient, you can't generalize from it, right? That's what happens in my work. Like, Tung's doing this great job with the Chinese people in San Francisco. And they're like, yeah, but how many people are Chinese people in San Francisco? What does that mean to Chinese in New York? Or what does it mean to white people in the southern, in Alabama? I'm like, yeah, but that's what we're doing the other way, right? So let's just call it what it is. I think the last thing is to engage diverse people and diverse communities, which you've heard over and over again. You don't need me to say that, but I just want to remind you that we need to involve them from the very beginning. Again, CBPR, Community-Based Physical Research, does that. We say start with the beginning, with the moment when you thought about the idea. Like, is this a good idea? You need to engage the community right then and there. If you engage them after you come up with the idea, then you already set parameters around what the science that can be done and what the effectiveness that works is going to be. And you have to take them all the way past analysis and dissemination, and you have to take them into policy and advocacy. Because fundamentally, actually, and I've learned this, I'm a very successful NIH-funded researcher, but nothing I do ever gets sustained or disseminated until the community thinks it's important enough to make a policy advocacy statement to their Congress people or to the government. Okay, that's when we talk about the impact of our work, that's what we're talking about. Now, this also feels hard because as a researcher, we're like, oh, I'm already having a hard enough time managing my staff and my grant officer and all these people. How am I managing all these people in the community? There's a saying that if you want to go fast, right, you go alone. And if you want to go far, you go together. I think a lot of us have heard of that. I say different. I say, if you want to go fast to the wrong place, you go alone. But if you want to go fast to the right place where everybody wants to go to, you go together. I actually don't think it's more work to do engagement if you define the impact of your work appropriately. It's actually faster to do engagement to get to the point where you want to go. Last thing I'll say, and to be more practical here, part of my job is to develop resources to help people like you to figure out how to do this. For both all kinds of research and data work, our Clinical and Translational Sciences Institute, or CTSI, we have consultation services now on how, number one, there's a consultation service on how to recruit diverse participants. So if you're interested in that, we can provide that. How you can engage communities. So for those of you who already know how to do it, you may be our consultant. If those of you who don't know how to do it yet, we actually have a free 1-hour consultation on how to do that. We also have a really new consultation program, which I really love, called Impact, which is the idea of what happens after you've done your research project. How do you get impact and policy out of that? I think a lot of us could use that. Like, a lot of us tend to go, oh, I published the paper, I'm finished with the grant, I'm done. And that's really not how you should think about your impact. But also, that's also why community end up hating us when we say we're from UCSF. They're like, oh, yeah, done, they published the paper, and they never came back. And we're like, well, that's because we're not thinking about what's the impact of our work, and we're not thinking about capacity building after the work is over, right? Well, this particular consultation service can help you think about that. And then Jen James is leading our brand new consultation service on anti-racism research methods. So vis-a-vis a lot of the things that we're saying about, like, how do we communicate? What are the structures underlying our assumptions? This is anti-racism in research. This is different than health equity, by the way. So health equity is really about making sure that the work actually doesn't make things worse and making things more equitable. But as you said, if you're not looking at the structures, then you're not going to get there. And that's fundamentally when you talk about health equity, if you aren't willing to look at structural problems and fix the structural problems, chances are it's going to be hard to get to whichever definition of health equity you want. My office is also committed to training BIPOC students and community people to do the scientific work. So we just launched a very cool thing called the SF Bill Office. It's an institutionally supported office between UCSF and San Francisco State University, which is a minority serving. We all know what San Francisco State University is. Does anyone know? I'm going to ask this. Do you know how to get to San Francisco State University? How many people do? Raise your hand. Only half. Okay, so that's they're like our neighbor institution, and yeah, they have thousands. I'm very fond of this saying, like, they have thousands of BIPOC students. We don't have to go looking for our staff and our trainees in places where there are few BIPOC students. And you know that's going to happen more now with the recent affirmative action decision, is that we keep going to Harvard or Ivy Leagues or whatever, those numbers are going to go down, and that everyone there is going to be fought over by every single institution. We have thousands of people here that are going begging. I mean, with people from San Francisco State, the professors that say, it's really sad. We have these people who are highly trained, very smart in STEM fields, and they can't get a job. They end up working in Nordstrom or something like that, which isn't, there's no shame in it, but that's not what they were trained to do. And we're not hiring them to work at UCSF. So I'm like, what's that, right? Anyway, we have this program, so please connect with us. We also have a circle training program where we work with diverse people to have them become clinical research coordinators, with the idea being, number one, these are good jobs. Number two, these are pathways to research careers or even clinical career, because a lot of our clinical research coordinator who are hired here end up going to a professional health school afterwards. And then, of course, they are, of course, more culturally appropriate or competent to work with diverse populations in our research projects. That call for Circle trainees is going out soon in the next couple of weeks. And we made a conscious decision, not just with working with college graduates from San Francisco State, but we also think that people from the communities are more than qualified to be clinical research coordinator. That may be an idea that some people may have trouble wrapping their head around, but actually there is no requirement to have a bachelor's degree to be a clinical research coordinator. And as I've said, I'd rather take a person from the community and train them how to do science than to take a scientist and train them how to be in the community, right? So that's the goal of that project. I'm here to help you in every way, shape, or form. So if you're committed to health equity, we're here to help you. That's the end. Thank you.
Thanks, everyone. We've reached the end of our program. Can I get another round of applause for all of our speakers and panelists? I hope you will all join us. I know you've joined us a lot today and brought a lot just by being here. But we are hosting a reception at Harmonic Brewery over at the Chase Center until 5:30. If you'd like to continue the discussion over there, it can be hard to find. You have a map on the back of your program, and there will be several of us walking over if you'd like to walk together. So, thank you.
Good job. You got me recorded. You're gonna end up with some. Yeah.